the entire event. It's going to be a few hours, but everything is going to be rewarding at the end of the day, because we are talking WASH. And today we unveiled some of the startling findings about where the country stands in terms of WASH in healthcare facilities. WASH is water, sanitation, water and sanitation hygiene in healthcare facilities. And before I actually proceed, I really want to commend our conveners, that is Engineers Without Borders in conjunction with PACE. I want to welcome our partners, UCMB, UPMB, thank you for coming. I want to welcome our regulators from the Ministry of Water and Environment, Ministry of Health. I want to welcome all of you. Each person in this room plays a very significant role. That should tell you that the conversation that we're going to have will invite you to be part. And in a very special way, again, I want to welcome our virtual audience. Hello there. It's a bit crazy speaking to a person you can't see from the other side. But maybe it's one of the new normals that we have to embrace. The world has now opened up to the virtual space. So I'm talking to people in China, I'm talking to people in the US, I'm talking to people in Iceland, and here I am, crooked as I look. So it's a pleasure for me. Ladies and gentlemen, shortly we'll be doing breakfast. We need to jumpstart our brains because the session that we're going into is a bit hectic. We need to jumpstart ourselves and be in the mood. But in the meantime, there's plenty of literature that you can keep referring to. I'd rather, instead of reading newspapers are just inundated with stories, some stories that might not connect with what is happening. You can't be here and then start reading about teachers' strike. Let's put our focus on WASH. It is a morning, a day of WASH, and it's going to be a moment of new beginnings, ladies and gentlemen. After the findings have been unveiled to us, we'll be making new resolutions and then pledging to start afresh and see where we can do better. Thank you for coming. I see maybe it would have been part of the house rules to mask ourselves, but some of us have been triple vaccinated. Probably I can relax that one. But another house rule that I really feel we must observe is keeping our phones in silent mode. Kindly, some ringtones are just disturbing. Some ringtones are scary. So let's keep our phones in silent mode. We shall limit our movements, save for the master of ceremonies. The moderator will have every right to walk around, but the rest of us, kindly restrict your movements. Let's participate. The key thing here is tapping from your port of wisdom to hear what you have to say. And you can stretch. In case you feel you've sat for long, you can stretch. That's it for now. Before I announce breakfast, I would urge all of you to keep the conversation going. Let's be chatting in the meantime. Let's get to know each other deeper. and to exchange business cards. Thank you. Ladies and gentlemen, breakfast is ready. So we can all walk out of the hall, go to the serving points, and then serve ourselves to a good breakfast. Let's give it 15 minutes, or we can make it a working breakfast. You grab your tea, come back. What do you think? I think we can grab our breakfast, come back here, and then in the next few, we'll be starting. That's good. So we're not going to ask you to be ushered. Just walk yourself to the serving points, and then you'll be served. Thank you. All right, ladies and gentlemen, welcome back from that very short break. And I hope it has energized us to start off with our workshop. Technical jargons like workshop are scary. Yet if you just say the meeting, people would treat it, would really feel part of it. And we want you to be part of this in a very special way. I went to welcome whoever's just joined us. We have in our midst Honorable Solomon. He's the chairman of the Parliamentary Committee on WASH. So he gets things moving. He's our voice in the August House. So, Honorable, we want to welcome you very much and thank you for coming. Ladies and gentlemen, now that we are good to go and relatively fully constituted, shall I ask you to stand up? I need to correct the misrepresentation of Honorable's name and title. He is Honorable Silas Awogon. When we were in school, they taught us about syllables and those things. We are talking arts. I didn't know A and O can come together, but he's here. Awogon. Good to have you, Honorable Silas, from Kumi Municipality, and he's the chairperson of the Parliamentary Forum on WASH. So, by extension, we all become part of WASH. Ladies and gentlemen, shall we stand up for the national anthem? And thereafter, I'll invite Reverend Father Mutiaba to lead us in prayer. Oh, Uganda, may God uphold. We lay our future in united, free for liberty, together we always stand. Father, will you come and lead us in prayer? Shall we remain standing?
Can we sing again? Praise him, praise him, praise him in the morning, praise him in the noontime. Praise him, praise him, praise him when the sun goes down. Serve him, serving, serving in the morning, serving in the noontime, serving, serving, serving when the sun goes down. God our Father, we thank you for all the good things you give us. We thank you for all that we are doing, the work we are doing of serving our people. We thank you for granting us generous mercies. We thank you for all the people of goodwill. We thank you for this day and for the activities. We pray that you send us the Holy Spirit to guide us. Whatever we're going to discuss, whatever we're going to hear, may help us to serve your people and to glorify your name. We make this prayer through Christ our Lord. Glory be to the Father, and to the Son, and to the Holy Spirit, as it was in the beginning, is now, and ever shall be, world without end. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you very much, Father. We shall now resume our seats. Good morning once again, ladies and gentlemen. Good morning. My name is Simon, and I want to welcome you in a very special way. Today, we are talking wash, and there is some good stuff for us that will be coming in the course of our workshop. I want to welcome in a very special way everyone who has traveled from near and far, and our virtual audience. I gather there are quite a number of people who are logged into this workshop. So that makes this a global summit. You're here and abroad. Ladies and gentlemen, I'll at this juncture invite one of the very key people, a chief engineer with Engineers Without Borders, Gerald, who traveled all the way from USA to come and be part of this, to share with us the opening remarks.
Thank you. I'm taking off my mask because I've been told that I have a bit of an accent. So make it a little more clear. So I would like to join our good Master of Ceremonies in thanking you for being here, for taking time out of your busy days to join this session and come together around this issue. I particularly like to thank the Ministries of Health, the Ministry of Water, the local district government here, and also our partners, UCMB, UPMB, and PACE. And I hope that list of partners grows as we get further into this effort and work on WASH in healthcare facilities. So we are here primarily to hear from the Engineers Without Borders team that performed an assessment on WASH in institutions across a number of regions of Uganda. But today, we're here particularly to hear about WASH in private non-for-profit healthcare facilities, UCMB, UPMB, PACE, because they have special challenges and special opportunities that we need to think about and we need to try to work through as a team together. We did this assessment and we gathered the data because that's always the first step. Good decisions are based on good data, on a good documented understanding of the conditions that actually exist on this front line of healthcare, where these healthcare facilities are seeing patients every day and taking care of patients every day. For us to understand the needs and challenges and the hard data at that front line, I think is critical to our success. I think another critical factor will be coordination and collaboration, two critical factors. And coordinated collaboration between all the partners that we have now and that we hope to recruit for this effort, because this effort is far larger than any single organization in this room. So this is the beginning, a small piece of, today we're going to focus on data, but we also are going to make some remarks. Peter's going to make some remarks on coordinated collaboration and how we can do that better. And we're going to also think about the future and what's the next step. I always like to leave a meeting with what's our next step. What are the action items that we do? So we have a packed agenda this morning. So I think I'm going to turn it back over to our Master of Ceremonies to get things going and to and let's get on with the program.
Okay, thank you very much, Gerald. He deserves another round of applause. Goodness, that's just not a bit of an accent.
Sorry.
It's a real accent. But our business today is WASH. Like Gerald said, we have a packed agenda. And I know most of us are eager to hear about the findings. It was such a tough job, but at the end of the day, we have something to write home about. And well, I'm just imagining that this work would not have been possible without the input of the key stakeholders, that is the Ministry of Health and the Ministry of Water and Environment. Our role as engineers was just to propel what the ministry is doing, what the two ministries are doing. So I feel it's prudent for us now to engage someone from the Ministry of Water and Environment, from the Ministry of Health, to give us an overview, to paint for us a picture on where and how the situation looks like and where it's headed. And that is none other than Commissioner Dixon, who is going to share with us the true perspective, how things stand in terms of environmental health and the WASH situation in Uganda's health sector. WASH is not simply WASH. WASH is water and sanitation, hygiene. So we're talking wash in healthcare facilities. May I invite you, Mr. Dixon, to come and make your presentation. I'll sanitize for you first. This is another new normal.
Thank you. I think you allow me also to remove my mask. Thank you, moderator. I also add my voice to welcome everyone to this workshop. Especially, I take also my gratitude to welcome the engineer from all the way from US. I also take this opportunity to welcome our own, the chairman, WASH Forum Parliament, Honorable Silas. Thank you. We appreciate whatever you are doing for us as the WASH Forum and the Parliament. We are grateful over that. I welcome all my colleagues from Ministry of Water, Ministry of Health, all the partners present, the religious leaders, and all the thanks goes to the engineers without borders who have made us to be here today, because without them, we will not be seated here talking about WASH. So it's great to do that. Yeah, as Minister of Health, especially the Environmental Health Department, we are the ones mandated to look at WASH, because ministry is a big thing. So under Environmental Health Department, we are mandated to follow up issues with WASH. I'll first register the apology. My commissioner and the director, anytime they will be joining us, but they are being held somewhere. So there I'm standing in as the commissioner, but anytime. And I pray that when they arrive, they be given a chance to do what? To give some remarks. Oh, I can't use this because I have to follow the presentation the other side. So the overview of the implementation of environmental health, you see, as a department, we have also Vector. We have Vector, then we have the division of that is inspection and safe water. That's what we look at. And as a ministry, we are trying our level best. Move on to look at the sustainable. To move at the sustainable, look at the sustainable development goals, the 6.1, 6.2, which gives us the mandate to look at sanitation, hygiene, and women, girls that are in a vulnerable situation. And that mandate is that by 2030, for instance, we should be open defecation free. Our wash system, we should be at the basic. That means almost all our health facilities should be having basic sanitation as a country. That's what we are looking at. So the status of sanitation and hygiene in Uganda, access to any form of sanitation, we are looking at access, whereby just anything, we are at 78.3. But when we look at basic, according to the GMP standards, that one is still lacking. And that's why I call for Engineers Without Borders and other partners here. We need to work hand in hand to improve. Because basic, even shaming, but we are roughly around 28. That's basic. Now, where Uganda, you feel like, I am okay here. Then about 2 in 10, they are still using bush. 2 in 100, they are still using flying polythene bags, for instance, around the slums here, but not even slums. There are some areas you may be witnesses, even in urban areas, if you move around Kololo, you will find vuveras with some things. So half of that household latrines provide some water for hand washing. That's around 51 people with hand washing facilities. So individual constraints as a department, about 5 in 10% attributes to financial constraints. Then we have 10 attributed to cultural beliefs, inadequate space, why people don't put up these wash facilities. And especially when you look at health facilities, now we give priorities to things which don't matter. And that's when I want to call upon our partners to help us, and when it to improve on budgeting for wash, especially when health facilities. You find that when it is time for budgeting, people prioritize other things. People think when they have bought a jig, they have bought maybe liquid soap, that is wash. And I call upon engineers without borders, because we have started this, to improve and do the capacity building of health unit committees, management committees, because they are key when it comes to budgeting of health facilities. So as a sector for sanitation improvement, sanitation activities have inadequate public funding and incapacitating implementers. Now that's why when we see people like Engineers Without Borders coming up to advocate for WASH as a ministry, we are very happy. Because this is a part where most people don't value. Because apart from the patients who suffer when they go to the health facilities, for us, when we sit here in your shoots and you don't want to mind. Because when you go to a health facility and you check the key critical points, say maternity, the lab, and they don't have water. You go to OPD, you find 1,000 people sharing that, the two stances. You look at an incinerator, people are doing open burning. Hey, I'm sorry to preempt maybe the report. This is what will come out in the report. But I'm trying to bring out to show how WASH is not given priority in health facilities, but even general in the communities. So we are looking at encouraging communities to form bylaws at village level, at sub-county, to enforce this. Why we are calling for this is to enforce the sustainability of the results. For instance, if Engineers Without Borders are working with the communities, you leave these communities, you give them results, but when you go back after 2 years, the results are not there. What could be the cause of this? So we are saying, can we improve and maybe do some capacity building to the local leaders to form bylaws? We have enforcement of legislation, policies, and ordinances. We have inadequate staffing from national level to the district. We have the issue of transport and the tooling of environmental health officers. The director, Engineers Without Borders, can be a witness because he did this. The structures he was using, he had to facilitate maybe them because they didn't have all that. We have poor performance in a review and the feedback system. This one comes back to reporting. How do we report? Engineers Without Borders, do you share with us data at national level like you have done today? Wow, you are doing it today for only the workshop. Then the other days you will forget us. So we need to coordinate. That data should keep on trickling at our office so that we also know what the Engineers Without Borders are doing wherever they are. Okay? Okay. So what are we planning? Like open edification status and the accelerated basic sanitation throughout Uganda by 2025. That's our roadmap. We have, I don't know whether Engineer Without Borders, you got it, our ODF roadmap. It has all those wash components. We are looking at how do you attain ODF, but not only ODF, we are looking at wash as whole, sanitation. When you got a household, do you look at only latrines alone, or you look at other key indicators that are needed as wash? So even at health facility, as you are doing, you need to look at all those components together. So we are looking at increasing general awareness and triggering the mindset change towards ODF and wash as a general thing. To improve access to affordable sanitation technologies. Yeah, now like Engineers Without Borders, we welcome you on board. We want new technologies. What should we do to get there? Because the SGD stock of 2030. But for us, our roadmap, we are looking at 2025. So what should we do? Where do you come in? We move as a team. We also ensure we are emphasizing adequate financing of sanitation program. I'm very happy. My chair from Parliament, they are the ones appropriating the budget. I'm sorry, I don't know what this time he gave me, but I'm very happy because he advocated for increasing environmental health staffs, the health assistant. I saw that in the budget, and I'm very grateful for that. We are looking at instituting and strengthening appropriate institutional arrangement for effective implementation. Like I'm saying, in our budget, they have talked of increasing on the number of environmental health staffs, and that one we are optimistic that it will go up to the parish level, and once we get them at parish level, that will be effective services being provided to our people. We are looking at sanitation and hygiene standards in all communities. How do we enhance them? That's the question now to our brothers, other partners who are here. So what do we need to do? We need human resources. Like I've said, we need some financing support. We are looking at that figure we have put there. It was a study. We looked at the amount of money. Honorable Chairman Wash, we were looking at how much money do we need to turn a village open defecation free. And we're saying only 4 million. Can you imagine? Very little money. And when we use those 4 million to turn a village, do you know how much money we shall be saving, which goes on treatment? It's a lot of money. It's a lot of money. And we're looking at that 15 billion would be converted in 20% of the household into open defecation free status. So, brothers and sisters, I take this opportunity to welcome you all, but that was just a brief overview of how sanitation is in Uganda and also in the healthy facilities. I welcome you all, and I say this for God and my country. Thank you.
Okay, thank you very much. Very shocking data. And maybe, I don't want to preempt, but perhaps at the end of our workshop today, we'll move with a resolution that at least if every year we can create about 30 villages where people do not have ODF. I don't want to pronounce it publicly. It's shocking. In the 21st century, we are grappling with such problems. But it's the reality. We are here to speak the truth and nothing but the truth. That's where we stand. And perhaps to add to the presentation of Mr. Dixon, I believe Dr. Hillary from the Uganda Catholic, the Protestant Medical Bureau. Oh, oops. What a morning. It's the end of month. Uganda Protestant Medical Bureau, Dr. Hillary will also be sharing with us about the role of the private, not-for-profit healthcare facilities, the role that they are playing, and how they can up the game, especially in the WASH campaign. Dr. Hillary, please come to the podium. As he comes, ladies and gentlemen, I will encourage you to take notes. Yes, you need to take some notes. These things are for your reflection on the way forward. And I know along the way, there will be space for you to make your contribution, to share your view on how better we can prop the WASH campaign. I'll also invite our virtual audience to keep the comments coming. Let's hear from you. Let's know what you think and tell us how you're doing. That side. I think I can move this podium. Yeah. IT, does he need to log on? You know, my IT savviness is so limited. I did arts. And we are the ones suffering now. You know, you become an outcast because you did arts. But I'm proud to be rubbing shoulders with engineers in the room. I believe Gerald is not aware of the arts sciences joke that's doing rounds in the country. It's very interesting. During tea break, we've already done tea. During lunch, I'll tell you more about it.
I request to unmask so that I'm audible as the presentation is loaded on. Thank you. Just a moment. My name is Dr. Alima Hillary, again, from Uganda Protestant Medical Bureau, and I'm here to make a presentation on the PNFP health subsector contribution to the Uganda health system. I first want to begin by thanking Engineers Without Borders for this opportunity, but also the partnership that we have recently enjoyed with them. I think a lot has been done. We're looking forward to hearing the dissemination of the findings, because we think it is good to go beyond the health sector to be able to find solutions for the health sector. So most of the time we've been working with health workers in the same area, but when you begin to cross beyond the health sector, then you're able to look at things a little different. And so we are glad that we are having this team coming in that worked with us so that we can see how it looks like from a different perspective. So we are happy for that. Next. I don't know what happened here. Okay, so that's my outline for the presentation. We will briefly talk about the PNFPs, then look at the contribution of the PNFPs to the health sector, and then challenges affecting the contribution or areas of opportunities. So these challenges are really opportunities. And as we discussed today, I'm sure they will show strengths, but also show gaps. And these are opportunities for us. So we will not be crying, but we'll be talking about them and seeing what we can do. Then some recommendations going forward. Next. So who are the PNFPs, private not-for-profit? Next slide. So this includes civil society organizations and of different forms, as we shall see, non-government organizations, and you will hear all sorts of terminologies, bureaus, you'll hear facilities, NGOs, CSOs, and all these are terminologies that are used in describing the PNFPs. The ownership is private, that is non-state, so when we're talking public against private, we talk about the PNFP facilities. So usually function is in the public interest. I think this is a very important statement to make. So as we speak, when you see surplus, when you see increase, we're talking about public interest. First and foremost, reason of operation is provision of health services. And this is from long time memorial. We'll be looking at briefly at the history of PNFP facilities. And for this to happen, for them to be able to provide the services, there is need for money. We know that we began with a prayer, we go to church, but finally when you come down, all this must translate. All your efforts must translate to a resource to offer this service. So if no one can support, I think this is a very important statement, that if no one can step in to support the end user of the services, it finally goes down to the end user as an out-of-pocket payment. I think that is very critical. So if we have funding at 20%, you know that if someone else is adding another 10 or another 20, finally the balance goes down to the end users. So as we talk about funding for PNFP facilities, we must know that we are looking at reducing the out-of-pocket for the communities and then increasing support for them. And in other ways that we have done, we've helped them to work with the communities to pull resources and different kind of innovations to be able to receive services. So surplus is not distributed between owners. So you don't have some directors who say, now this month we have a profit, we will take 30%, I'll take 20%. Whenever anything that looks like a surplus appears for the PNFPs, this is put back in the pool to improve services, increase coverage, increase quality of services. So the resources do not go out for someone to go and say, I have this amount of money in my bank account. It remains within the pool. So I thought this was very important in understanding how PNFPs operate. Next slide. So the two major categories, we have the facility-based PNFPs, which is a majority of what we're going to be talking about today. Then the non-facility-based PNFPs that help a lot with the community activities that we have. About 75% of the facility-based PNFPs are under 4 national faith-based coordinating bodies. We call them medical bureaus, and we'll briefly be talking about them. Just to mention very importantly that as PNFPs are working with the oversight medical bureaus, we do have the second largest supply chain mechanism in the country. That's Joint Medical Stores, and we are proud because Joint Medical Stores is growing, and it is co-owned by Uganda Protestant and then Uganda Catholic Medical Bureaus. And this has been able to support in alleviating the challenges in supply chain. And this was founded in 1979, and since then we have seen a lot of growth. Next slide. So that is just a picture, and this picture keeps growing, I must say, every month. So you have new PNFP facilities coming up. So if you went back maybe a month or two later, you'll find the picture looking different. The next. So this is specifically for UCMB, and the other one was for UPMB. So the facilities are increasing in number. And as this happens, I want to mention that they grow in stages. So a facility that has been around for 50 years will not be at the same stage with a facility that began probably 2 months ago, and depending on how it's being funded or supported. Next. So for the non-facility-based PNFP health providers, so these do not directly own or operate health facilities. They support undertakings in the community area, and they partner with facilities to make sure that services are accessed. I think the recent COVID-19 experience has changed the way we look at health services. So previously, most people would be going to the health facilities, but the lockdown taught us that in such a situation, you should be able to offer service in the community adequately, especially for clients who are having chronic care. That means every month or 3 months or 4, they need to collect treatment, have an assessment, take some samples. So they need to work closely in the community. I think is something that is growing so much. And so we're working on how do we build capacities in the community such that services are provided. So the non-facility-based PNFPs are very helpful in this. They support preventive measures, promote good health, but also are trained to be able to offer some level of health care. And so they do support the government and also PNFP facilities that are existent. And they include international, national, and local NGOs, and then CBOs. Next. So this is the list of the 4 medical bureaus. We're working very closely together and learning from each other. There is a lot to learn. When I sit with Dr. Kasiaba, we will talk a lot about trends, experiences, practices. You're welcome, sir. So we have UCMB, that is the Catholic Medical Bureau that was founded in 1934 under the Uganda Episcopal Conference, and then Uganda Protestant Medical Bureau. This includes the Protestant churches, and this is not simply Church of Uganda, but Seventh-day Adventist and Pentecostal churches do come under the UPMB umbrella. And then the Muslim Medical Bureau is the other that was founded in 1978, but reactivated in 1983. Again, continues to grow and also support service provision. And last but not least, the Orthodox Medical Bureau that is more recent than the others, but also playing a very key role in terms of providing services. So these medical bureaus have platforms where they sit together and are able to discuss how to improve the quality, but also access of services. We do work together when there are opportunities to see how to scale up services in the community. UCMB and UPMB were gazetted in 1955 and 1956, respectively, as channels for giving grants to aid religious founded facilities. Next. So what is the contribution of PNFP facilities to the health system? So this shows the areas that they contribute all through the health system building blocks. And if you look, you will see right from the area of policy, leadership, and government. This is very critical, especially for PNFP. If you look at the structure for public facilities, you're having Ministry of Health and all the way down to the district, to the health sub-district, down to the facility. Now, for the PNFP facilities, it is very important that this is strengthened. Why? Because you will have individual facilities, and if there are issues with governance, you're going to have problems. They will not be run well, resources will not be managed well, staff human resource management issues, resolving of emerging issues at the facility will be critical. So for the PNFP facilities, this is very, very important in terms of leadership, management, but also adopting and utilizing the government of Uganda policies in terms of providing services. Health financing is very, very important again. And we want to appreciate the support that is coming from government of Uganda. I'll be sharing some figures to support provision of health. But we know that even as we go on, the needs are growing. The needs for health are growing. Chronic diseases are increasing in the community, and this means ongoing care. But also the scope of care, complications, things like COVID-19 are coming in. The cost of implementation is growing up. So even as that is happening, I'll be sharing that the needs are also growing. Human resources for health, very important that we build human resource, and there are unique issues about human resource for health for PNFP that I will be mentioning. Very importantly, health information and communication systems. How are we able to use our information? How are we able to store it and then be able to plan using this health information? Medicines and other technologies, we'll talk about that briefly. Service delivery and referral systems, working with the government. There are districts where you'll find a PNFP facility is actually the district hospital. And so if you're not working closely with the system that has been set by the government, there'll be issues of referral, managing clients, and also sustaining the quality of services. So we have worked very closely with the districts and the different structures to make sure that we have quality services in our facility and down to the end user. But you see, we're working closely with country Ministry of Health, down to the districts and then to the health facility. But also to mention that for the PNFP facilities, especially those that are under the faith-based bureaus, there are structures that are working along to support this. You have the example of the diocesan health coordinators. We might have some here, I don't know, but we could be, yes, thank you for coming. So they play a very key role in terms of supervising and providing support for facilities in particular coverage, but also working closely with the district, working closely if there is a fund or a project, working closely, and they've been very, very useful in terms of coordination. And so this, along with the structures that have been set up by the bureaus, do work to offer services. Next. So this is a brief on the history. As you can see, the number of PNFP facilities initially was slow in rising, but you notice in the period when we had conflicts in Uganda, there was a sharp rise, which for me is a good thing. It means there was a response to the challenges. If you go to, for example, northern Uganda, where there was war over long periods of time, the PNFPs did really play a key role in improving access to services. So you'll find there is a public health facility, but if you go, 20 kilometers, 30 kilometers away, you want to see coverage. So they would come in to be able to support working with the public health structures. So we see a big rise, and this, like I mentioned, continues to rise. And so importantly, how do we support this rising number of facilities with the support they need to be able to offer the services we require them to? Next. So policy development, monitoring and evaluation of the national plan, very important. We have been involved and participated in the national processes as PNFPs for developing policy and bringing in the perspective of the experience for the PNFP facility, so it is inclusive. And so if you look at the sector-wide approach and the structures that are in place, health policy advisory committees, we are part of them, and then at the district level, even recently, I think when we're having the lockdowns, if you look at the task forces, you'd have the PNFPs also participating in this. And then we also have definitely the medical bureaus that I've mentioned that are self-coordinating bodies, but working along with the existing national structure. And then the non-facility-based PNFPs like I talked about. Planning and coordination, very important that we are involved in through established coordination structures. We are able to share information on trends that we see for health, for disease, but also emerging needs in the communities and the facilities. Like we'll be talking about for WASH. What are the needs in the community and how can this information translate into policy? Very important. Next. So the other area is health infrastructure. Just a few pictures of what is going on. A lot is being done. And we know that health infrastructure is so important in health delivery, because without the infrastructure, you definitely are going to have issues going under trees. But also, if you look at the way support is given, you need to have certain forms and levels of infrastructure to be able to get certain kind of support, because no one is going to give you theater equipment without a theater. So they will ask you, can you get a, if you have a theater, we come and assess you, we can give you the equipment. Some will tell you, we cannot give you this level of specialist if you don't have infrastructure developed to a certain level. And so it's very important that along with all the other support that we're giving, that infrastructure is targeted. So about 42% of the country's hospitals are PNFP facility, which is significant if you look at it. So if we had an issue with all those 42% health facility, there will be a national crisis, and so we don't want to see that happening. And then 42% again of the country hospital beds are also in PNFP facilities. So you see, the information that comes from these facilities is important in terms of planning, such that nationally we have a good coverage. About 65% of the institutions training nurses, midwives in Uganda are PNFP owned. And that is critical. I'll be showing some data about the courses that they are offering, but also how they are supporting human resource for health. And 92% of these are under the 3 medical bureaus. Next. So this shows the number of facilities by level. As you can see, UCMB, UPMB, UMMB, and UOMB, a total of 678 facilities, which is a massive number of facilities. And this relates to the 42% healthcare that we're talking about. I put question marks for other PNFPs because we know there's a lot of cropping PNFPs, and the need for us to get a systematic way of knowing who's where, such that we're able to coordinate service. I think this is something that we are pushing for, coordination for PNFPs, whether they are under the umbrella bodies or not, such that we can track. But you can see the hospitals, about 58 hospitals nationally. That is significant. And so when we discuss the contribution of PNFPs, you can see that this is important. And like I mentioned, there are areas that are majorly covered by PNFP hospitals. And so the importance for us to discuss and think about them as we plan. Next. So you can see the percentage, 43, 38, private 18% of the hospitals. Next. So this is human resource for health. You can see the numbers, about 16,893 human resource for health. And I must say, and this is something we have been discussing, that this figure is actually like this because a lot of staff have moved on to the public facilities. This is a critical thing to talk about. So if you look at different facilities at different levels, in terms of remuneration, their levels they can afford and what they cannot afford. So you see now there is industrial action and they say, we're going to raise the salaries of health workers. That does not happen at the PNFP facilities. These are mission hospitals, people go there knowing what is there. And there's a lot of commitment. I must say there is a lot of commitment at the PNFP facilities. And so if you look at in terms of attrition is very high. And what happens is that people come, they gain experience, they get really good, and then finally move to the public facilities. And I'll be sharing some information on that. And so the good experience is coming. Thank God that even as that is happening, more people are coming in. But you can see still, despite all that, there is a massive amount of health workers that are in the PNFP facilities. So 10,000 for UCMB, 6,000 for UPMB, 540 for UMMB. And so to have structures to be able to motivate, retain, enroll human resource for health is very, very critical, considering the work that they do. So 10% of qualified clinical staff are seconded, deployed by government as strategy to extend services to the people. We are grateful for this. And we hope this number can actually increase. So if you're covering 42% of the country, then you'd probably want this figure going a little up. Yeah, because one good thing about secondment is that these staff they come in with the terms and conditions for the government. They will most probably stay there. They're not going to run to another public facility, especially the specialists. So you have hospitals that are running districts and need more specialists, but also in terms of coverage, there are areas that are very remote and need this coverage. So I think this is important for us to note. Thank you. Next. So this is in terms of training. So to be able to keep up with the staffing needs, we do have training institutions, and that shows the number of training institutions per each of these courses that are available. nurses and midwifery, enrolled midwives, laboratory staff, down to universities that are training postgraduate doctors, training in health service management. So this is a practice, I think also that we are bringing in. We are saying if people are going to manage facilities, and I talked about governance, they need some form of training. If you remember, for those who've been to medical school, you'll go and be taught how to manage patient clients, take care of them, but no one will take you and say, this is how you run a facility. And that's why in some institutions, some countries, you'll find health facility managers actually not doctors. They're people who are doing administration. And so it is important that our health workers that are running facilities are also trained such that they can manage the facility well, but also be able to sustain the services. So this is just a breakdown of the training institutions. In summary, UCMB has 15 health training institutions in the country. UPMB has 16 health training institutions, and UMMB 1. And that is, I think, about 32 health training institutions, a massive number again. So you see, if you have 32 health training institutions in the country, then it is very vital that attention is given to them. They are accredited, and want to thank the institute that accredits for the support and the response. They really respond well. The National Institute that comes to accredit our facilities, but they're also supportive. They don't just come to say we disqualify you. They come in to say this is what you can do to be able to offer this course. This is how we can maintain the quality. And I think that is also very important for these institutions. So we have health workers that are coming out that are able to offer services as they should be. Supply chain, I've already mentioned about joint medical stores, and also gladly to note that supplies, initially the PNFP facilities were getting their medical supplies from NMS, and some areas like TB getting through other facilities to NMS. But now I'm glad that the resources are now going direct, and we want to thank the government for that. That is a big, big jump, because if you have issues in ordering and reporting, because you either have to pass through another facility or another structure, it becomes a challenge. But now we can have direct ordering, and I think this transition has made a big difference for the clients too. So you have less stockouts and then good management of the resources. I think that's about it. Next. So this one looks at maternal health care for the facilities, inpatients and deliveries, and just to be able to look at the proportions that are coming in from the PNFPs. And the recent numbers are actually bigger than this, but you can see inpatient admission 42%, deliveries 20%, and OPD having 19%. And I mentioned that there's a few things, of course, definitely that have affected. If you're having user fees, and here there is no user fees. But you can imagine, despite the presence of user fees, that you have the clients opting to still go to PNFP facilities. We know regions where you'll find people moving. I think I worked in Kavale for about, 10 years. But you'd see someone leaving Kavale and saying, I'm going down in the forest, down in Chisizi to have my delivery there. And you'd ask them, what is there? Why do you want to go there? And the client will tell you, I think I will have good care coming from there. Oh, I want to go to Anyachivale Hospital. And you'll ask them, so why do you want to go there? And they will tell you it's about the quality of services. So we're working hand in hand with the government, and we want to appreciate every support that is coming through, even in this area. Next. So health resource mobilization. So this is another area that is very important, and a number of approaches are being used. Like I mentioned, for all the resources that are not covered, either through government, either donor funding, or any other individual funding, it goes down to the final user, and that is out of pocket. And we know the days and the times we are in, the economic times are really tough. And so in a PNFP facility, you can actually have a client who comes in, and after you started treating them, they say, I don't have money. So at that point, what do? Do you tell them, we are going to arrest you here, or we are going to let you go and we go to your home? It gets complicated. And so many times health workers face this daily. And first of all, you are a faith-based facility, and then you're PNFP. And so someone has come and is saying, maybe they'll be a little lenient to me, but I don't have the money. Or someone got an accident and was rushed to the nearest hospital. and you've admitted them, and then after they say, we are sorry, we are not, this was the breadwinner, and he's been here with his leg hung up all along, and so we are stranded. So when we have resources coming in for these facilities, they're able to take care of these clients and allow them to go home with dignity, you know, so very important for us. And so we are mobilizing resources from donors, very, very grateful. I think donors have also played a very important role. And donors, they're international donors, and then there are local, individual initiatives also to support facilities. And then mobilizing local resources. I think this is an area we're trying to build. Because if you look at sustainability, even as the government, the need for resources is growing daily. And so we are saying, how do we do this? We do have areas where we have community health insurance programs, and they are growing fast. Importantly is to be able to, what we do is we train facilities. We also train stakeholders in the communities and work with them to organize communities to be able to pool their little resource. So, you know, if I've paid my money there for a year, whatever happens to me, I will get a service. So in a way, you take care of everybody in the community at smaller cost per individual. So as confidence grows in the communities for the service, we see the uptake increasing. And the more it increases, the uptake in the community, the more it's able to cover, that pool is able to cover the needs. Because you might have paid 40,000 for your year, and then you fracture a leg, and the actual cost of care is 1 million. So if you're having other people putting in the pool, then you'll be attended to, and you get to realize that this is important for you. So we're having a number of facilities taking up this approach. Increased support from government or donors helps reduce reliance on user fees. I've already mentioned that. Very, very important for us. Then reduction in support amid this increasing cost of services forces PNFPs to increase user fees. So there are some PNFP facilities that have really found themselves in difficult places and have considered and said, I think we need to raise. So if a user fee is 3,000 shillings and someone in the care they're going to spend 50,000, someone needs to take care of the balance cost that is there. And so if the costs keep going up and the numbers for the user fees are not going equally up, then the challenge goes to, can we increase the cost for the user fees? And definitely our clients, our communities are affected by this. So this is important for us to also note. This shows, this was a previous slide, and I think we are doing a recent assessment, but you can still see user fees, big proportion, donations, very big, IGAs, important, and then government. But I'll be sharing that of late, I think we saw a bump in the PHC, primary healthcare funds that were coming in from the government who were happy. But of course, to note that proportionally, because the cost of implementation is going up, we still notice that in terms of percentage, it has not gone as high as we expected. Next slide. So this just shows you the trends, recurrent cost recovery rate. So whenever you notice that whenever the government comes in, then it is easy to have some resources around to improve the services and offer more. So there was a bump, and even recently we saw an increase because resources were coming in. But whenever you have reduced resources coming in, for some facility does happen, you will see the cost recovery rate being affected. Next. So contribution to innovations, performance-based financing, this has been good. We've been involved for some of the facilities that we have. Examples in Jinja, in Acholi sub-region, I think there's been a very big drive for performance-based financing, and we have benefited. One is that it has also motivated the workers to work hard to offer quality services because there are assessments for the quality services, but also support coming in for them to improve how they offer services to the client. So performance-based financing has been a key innovation in terms of offering services. Voucher systems have also been done with external funding. We've seen some for maternal care and deliveries, and when this has happened, it has worked much to lift the load from the facilities. Next. Okay, I see the time is moving. I'll try to move a little faster. In terms of contributing to quality improvement, we are participating in national efforts by Ministry of Health for safety and quality, including the IPC that we've had assessed here. We've also been able to do surveys to look at our care, but also production of manuals, looking at the experience and improving the quality of care. Next. So health technologies, looking at use of data, taking up electronic forms for both logistics and then M&E has been very vital, because it means not only is the data put in one safe place, but also it means that it can be used both locally and remotely to advise service provision using the trends that are being observed. So this is something that is being scaled up. Facilities are being given computers, trained, but also helped to get online to be able to collect their data and also utilize it for programming. Next. So I think I've mentioned much of this, but just to talk about the community-based services that I'd mentioned, very important for us, improving and increasing need for community-based services in form of outreaches, points of care out in the community, so that communities are able to access services out there. So 70% of HIV community HIV services are actually being provided in the community. And so this brings services closer to the client and enables them to be able to retain in services. Next. So major challenges to PNFP, and I did mention the high staff attritions. You can see this is an example from UCMB previously used, and we have this ongoing to be able to assess. So you can see very high staff turnovers at the facility. 60 to 70% of the staff that leave these facilities go to the government facilities. Next. So this is the cost of service provision. I'd mentioned talking about the funds, and I want again to appreciate the government of Uganda for the support. We did see an increase from about 17.7 to 35 billion. That is, I think, 100% increase, which was good. You can clap. Yeah, so we really, really want to appreciate. As I've mentioned, it goes a long way in helping these facilities to offer the service the way they should do it, but also in terms of covering communities' access to care. You see that it is very important. For UCMB, the last from the year 2019-2020 to 2020-2021, we saw an improvement from 13.1 billion to 15.1 billion. And then for UPMB, 5.9 to 8.6 billion. That was about 47%. Very significant increase. So we appreciate that. So the challenge I think that has come in, as I've mentioned, is that the needs I think are also increasing. So even when you increase the money and the need is going up, it still remains at about 10% of your annual needs for finance. So I think even as we plan, this is something you want to look at critically. What are the needs? What information is coming down from the facilities in terms of need, and how can we do this? Also looking at the coverage in the communities. Areas where you see they are covering an entire district, health sub-district, and sometimes some districts have said it may take us a long time to put a facility in this place. And then they ask the PNFPs, can we set up an outreach? And those outreaches grow up into facilities. And so the need to cover those is very important. Next. So this is, I think, my last or second last slide, looking at where the costs do come from. So if you look at the different costs, there are costs that the health worker will see, or the facility, there are costs that the client will see, but all these must be covered, right from human resource. So these are visible to the health provider. But when you start coming down to the user fees, it is the client who's feeling that. And then there are these ones which come down, which are not visible to health provider, the transport, the movement, the coverage costs, all coming down to the community. So important for us to cover them. Next. So recommendations, I think for the human resource for health, it's important that we understand this. It is not as simple as it sounds. It is more complicated than even we think. I've mentioned the government, but there are many things that happen beyond just people moving to the government. But very important for us to understand what are the trends of movement for staff, but what are the things that motivate actually staff to stay at a facility so we can support this. I've also mentioned the need to increase government support, and I know this is something that is going on in terms of budgeting and planning, very, very important to take care of this need. And then human resource support, very important, but also infrastructure to go along with the services that we do offer. With that, I really want to appreciate again the invitation to come here, but also the work that we are going to probably hear about. Thank you.
Well, thank you very much, Dr. Hillary. He deserves another round of applause. He gave a very elaborate and stimulating presentation about the role of the private, not-for-profit healthcare facilities in promoting WASH. I tried to provoke the thoughts of our outer audience out there. I sent a tweet with some of the highlights of the presentation of Dixon. Apparently, some people are saying, hey, so you're shocked that there are no hand-washing facilities, that there are no toilets, that people are openly doing their things. I think as part of the game, we need to work on mindset change. There's a lot out there that people have come to treat as normal. But since in our midst we have a representative of people, I'll ask him on behalf of the people. That is Honorable Silas. Honorable Silas has been quite vocal in advocating for WASH. He leads the Parliamentary Forum on WASH. Before I invite you, Honorable Silas, allow me to welcome in a very special way the most distinguished guests from the Ministry of Health. That includes the Commissioner who will be inviting, Commissioner Moses Kabanji will be inviting the representative of the chief guest. But for now, Honorable Silas, I will go on. I appreciate this is a very hectic season for you. You're supposed to be monitoring PDM. But I think key in your address to your constituents, you should tell them about WASH, that we are giving you man on condition that you build toilets, you get hygiene facilities and washing facilities. May I humbly invite you to come and speak to this audience.
Thank you so much. And I'm happy that you've been able to pronounce my name very well. Most times, most people fail. Yesterday, we were at the Golden Tulip with I think water aid, and somebody failed totally to read out my name. And yet it was clearly written. Yeah. So my name is Silas Augon, Member of Parliament representing the people of Kumi Municipality in the Kumi District. Kumi District is in eastern Uganda. And we border the Karamoja region. The Karamojong are our uncles, so we have a tight relationship. If you get a combination of Karamoja and Teso, you know that's very strong blood. Yeah. I do chair the Parliamentary Forum on WASH, and I think I have my coordinator here. Jackie, can you please rise up for recognition? I want to thank you all this morning, and particularly Engineers Without Borders, for having taken up this initiative to convene this gathering as we discuss these very pertinent matters. Let us also applaud those who have flown in from without our borders to share with us.
Right now, the cost of fuel has gone high, and I want to believe even the tickets, the cost has gone high. Food, not only in Africa, but throughout the world, has become expensive. Everything is becoming expensive, and I want to believe even wash has become more expensive. Because it's a very, very important subject, I've kept on changing what I thought should be priority for me to say. I first wrote on page 1, I thought that was not the best. I opened the second page, I wrote something, I have abandoned. I wrote it in the third page, I abandoned. But now I've resorted to the last page, and I think I'll say just something about what I've put here. Just a few comments. First of all, as a parliament, you need to know we operate through committees. There's a plenary, yes, in the chamber, but the committees of parliament play a very big role. A very big role. When it comes to appropriation, legislation, oversight, those three, at least we work through the committees a lot. But at the same time, I need you to know that we have a forum. This one simply gives a platform for members who have interest in this subsector to concentrate. And I think as a country, that's a plus. Because the forum fits into the work of the committees. Directly, the Natural Resources Committee handles issues of wash. But this forum helps us. It's like a breeding ground where you build the capacity of members to deliberate, advocate, and handle issues of wash. Currently, we have well over 80 members of parliament under this forum. And if your hands have not grown cold, you can clap for that. Because you see in the parliament, for you to advocate, you need numbers also. You need numbers. Most of the issues are around voting. You can go to the floor, and then when you suggest, let us increase money for the private, not for profit, somebody will tear you down and say, no, we cannot do that. Let's first start with the public what? Institutions. But if you have the numbers, then you can be able to move. For that reason, the numbers become critical. And I want to appreciate Engineers Without Borders. Really, if you look at the figures, the contribution that has been made by the private not-for-profit health facilities cannot be just ignored. I think you are operating at almost a 50-50 with government. There are places where you even find that government facilities are not able to really cope up with the population needs. But these facilities cover for us. Therefore, when you see the interventions from government in terms of funding, it is to appreciate the role that you do. We want to appreciate the Protestant Medical Bureau. Can we clap for them for the first time? Because you've never clapped for them, maybe. Yes, they have done a great job. And for me, I was educated by the church, particularly the Protestant church. Therefore, whatever they do is always blessed, I know, because they blessed me, I came to parliament. I didn't have money, by the way. Today's politics is monetized. But as an orphan, educated by the church, they had already blessed me. I talked to the people, they said, you go. I came to Kampala. So what the church always does is blessed. Can we appreciate the Catholic Church? They have done such a wonderful contribution. Look at the figures and you know the role. And you know what they have, the contribution they have played. The Muslims. Let us clap for them. I don't want to be caught off guard. Somebody will say you went and became what? I don't want to behave like a scientist. What? No. Yes. Then the Orthodox. Let's clap. Let's not get tired of clapping. I heard of another one. Which one was that? You? The apostles. Eh? The Pentecostals. I'm also Pentecostal. You clap for us also. And then others. Where possible, government should be able to take over some of these facilities. That should be the way to go. Not only in health, even education. I want to cite one example of a university in eastern Uganda, Kumi University. It's such a huge university with a lot of infrastructure. The buildings are huge, but there is one issue. We need professors. Government could come, take over, pay for the professors, and you will see the difference. So likewise with these health facilities, it can work. If government comes on board to make sure that we have enough human resource, build the capacity, help in issues of governance, then you'll see a change. And now for me, personally, I'm concerned about issues of WASH. I can tell you this PDM that we are talking about should also get oriented towards issues of what? WASH. Let us take WASH to the parish level. And if we do that, you will see a change. If we are sending 17 million to a parish, can we get a percentage first to deal with issues of WASH? If only 4.5 million is needed in a parish or a village, can't we say that the first release should cater for that? First remove 4.5, deal with issues of basic WASH, and then the rest you continue with PDM. Will that be a mistake? I don't think. For me, I want to agree totally with Engineers Without Borders that government needs to come in, support the private, not-for-profit facilities in terms of WASH. Yesterday, we had a meeting with we had an activity with the Water Aid. They have been having a lot of work that they did around Kampala. With the municipalities like, okay, is Entebbe Kampala or Wakiso? I think that's the greater Kampala. I should call it so. Entebbe, Mukono, Kira, and then in Nansana, Machi in the Sabagabo, I don't know how they call it. That one. Some people call it Sabagala. When they get lost, they say Machi in the Sabagala. Because that is the easiest to say. What that interface with the mayors. And they played a big role, together with Water Aid, in improving WASH in these facilities, in their municipalities. And I thought that you cannot ignore the contribution made by politicians. You see, for us, we are not people of sciences. You will not increase our salaries, we know, because we are not scientists. But as a scientist, you may not be able to mobilize the people the way we mobilize. For us, we use our noise. And things happen sometimes. I also don't know whether scientists can pray properly the way for us we pray. For us, the people of arts. Yeah, that's the question for you. Because for you believe in the needles, this, but for us when we pray, the Lord listens very fast. We know how to kneel down quickly, but a scientist will take, first of all, wants to research whether the soil where it's going to kneel on has a scientific proof that if he kneels there, God will listen. Everything is about laboratory. You first want to check. For us, we are swift. So we need that increased collaboration between the scientists and, for us, the non-scientists. That is what I think. So, by and large, as WASH, our role is to make sure that we provide you with that access to Parliament. Because that is the theater where we do all the surgery, including the money surgery. When there is no money, it is difficult for you to move. But when there is money, even somebody who was in the bed reading, sometimes starts to speak out. So how much money? How much? So somebody can start to speak. Money plays a big role. So Parliament is there to appropriate. Parliament is there to legislate. Parliament is there to do oversight. I've also realized that when we just disburse money and we don't follow, Ugandans of today have changed. You sell somebody to the market with 5,000 and you don't follow him from behind. I can tell you, you cannot be sure of the results. So we have reached a level where you need to, when you send somebody, you send him and you also follow him. So the reason for following the person, I mean, for sending him, loses meaning if you send the person alone. You've got to follow from behind. So if you say that you are going to give 50 million, 50 billion, and then you don't follow, it is just the figures. It can be lost. Things have changed. I thank you. Health facilities, which are not for profit, need equipment. They need expertise. They need to maintain the standards. And I don't know whether the Ministry of Health, I think we are well represented here, has this aspect of quality assurance and observance of standards. Because today I'm telling you, people are sick. When you are sick, you don't check whether that doctor who is putting on the white, I don't know how they call them. Is it a gown? Is it a robe? Is it a cover? How do they call them? That one. A clinical coat. I saw in newspapers that police uniforms now are being sold on what? On the streets. And it's very possible that even for the medical, the clinical coats can be easily got. I get that thing that you put around your necks. I don't know how they call it, that tube. A sito, that one. Very difficult. When you put it with that jacket, I can tell you, you put it on, somebody who is down will just rush to her and say, I believe in this doctor. He's very smart, therefore he knows what to do. So, we would love to encourage Ministry of Health to do a lot of work around checking what is happening down there. Standards, quality assurance, capacity building, coordination, and then we move on. There is also a complaint that most of our budget for Ministry of Health is staying at the center. The money is not going down. So we need to look at our internals. The budget for Ministry of Health should be able to support these private, not-for-profit organizations more beyond what we have already done. And you'll see the country progress. I wanted to stay here up to evening. But because today, there's a minister in my constituency, people are already gathered, they are training on the PDM, I'm expected to say something. If I don't go, that might affect me in the other one. So when we say that we need a proper car, you people will complain, hey, they want a car for 200 million. I'm telling you, you don't know how we suffer. You don't know. I needed maybe an helicopter so that by now it should be warming as I'm preparing to go. But you think we just want this for just, it is not for fun. I can tell you, a member of parliament has a lot of responsibility. I want to thank you so much, but I know working together is the way to go. We shall increase our collaboration and coordination with you. We shall listen to you. We need to ride on the evidences that you give to us. That makes us people and real champions on the floor. If you stand up as a member of parliament to speak on that floor and you don't have evidences, you don't have research information, you look like wind yourself. You become useless. People just laugh at you quietly. They will not tell you that you are bogus. They will just quietly keep quiet. So, we need the research from you, from Ministry of Health, from the private not-for-profit. We use it for advocacy so that we can increase the resources. I thank you, and may the good Lord bless you. For those of you who are here and you are working with the government, as long as you are not corrupt, I've prayed for you. Government will elevate you to the next position. Those who are not corrupt. If you are not corrupt, yes, government will elevate you to the next position. And for those who are in the private sector, if you want to move to government, because now government is doubling the pay, increasing, you will get the job. If you are not corrupt. For me, I always pray and God listens. Sometimes God listens to me even more than he does listens to bishops and reverends. May you be blessed. For God and my country.
Well, what a way to spice up our morning. Thank you very much, Honorable Silas are all gone. The vowels are complementing each other. A, O. I wish there was an E. A, O, E, gone. But thank you very much. And your emphasis on WASH at the parish, rather in the PDM, is equally interesting. How I wish you'd prioritize people with WASH facilities to be recipients first. Yes, for you to get government money, do you have a toilet? Do you have hand washing facilities? Take money. That means you're responsible. Someone who goes to the bush should not get money. But you know, those people who go to bushes have more votes. So you need to be careful. Ladies and gentlemen, allow me to recognize in a very special way the presence of Commissioner Joseph Epitu from the Ministry of Water. Will you please stand up for recognition? We are really honored to have you in our midst. May I now invite Commissioner Moses Kabanji from the Ministry of Health to share with us his thoughts for the morning, and then invite the guest of honor to make his remarks on behalf of the minister.
Thank you, sir, for the moderation. Honorable Silas, we are surely very grateful that you've always been part of us. We were yesterday at UASNet celebrating 20 years, and then at Water Aid, and these were activities that were very close. And then now you're here. The small discussion I had with you, you indicated that you had actually jumped from Kumi to come and join in those meetings. We are surely very grateful. We don't take that for granted, especially at this critical time when we are advocating for WASH financing. Thank you very much, Honorable. The guest of honor, representing Honorable Anifa Kawoya Banjirana, the Minister of State for Health, our general duties, Dr. Daniel Chabayinza, but also the Director of Public Health in the Ministry of Health, where issues of WASH actually fall. The commissioners, Commissioner Joseph Epitu from Ministry of Water and Environment. Commissioner Liaisons, I don't remember the other one. Yes, I hope you'll be here to fully introduce yourself, but I recognize your presence here. Our development partners, especially the funding agencies for WASH, who are here, our colleagues who have represented, you call them the Christian bureaus. I don't know how we call them. They mentioned so many of them. The medical bureaus, yes. The UCMB, the Protestant Medical Bureau, the Muslim Medical Bureau. I also recognize your presence here. The heads of implementing bodies, I see World Vision here is represented, and the others that I have not interacted with. PACE, you're here. I know you're together with Engineers Without Borders. And then my colleagues from the Ministries of Health, Ministries of Water. Unfortunately, I don't see Ministry of Education here. We always move in three. We are triplets. And I've always emphasized this. For every meeting we go in as Ministry of Health, those issues of isolation should stop. We really want inclusion. We can't do interventions in WASH alone. Ladies and gentlemen, my name is Moses Kabanji. Mine is very simple. I can see you pronounce it very well. I work with the Ministry of Health, the Department of Environmental Health Services, and where the mandate for improved sanitation actually falls. Allow me to sincerely appreciate Engineers Without Borders for bringing us here together to be able to deliberate on issues that affect our people, especially to talk about WASH in healthcare facilities. I really want to appreciate you, Zaba. I don't know where your team is. I see you alone. I saw yeah, there's the other colleague. I surely want to thank you for bringing us together to be able to discuss the findings of WASH, especially in PNFPs. I think that was an oversight. Last time when we did a study, we moved to all facilities in the country, public facilities in this country, and we're able to come up with a report. But we missed out the issue of the private, not-for-profit facilities. So I really want to thank you for organizing this, but also for providing a platform for us to be able to advocate for WASH. It is through these platforms that we continuously engage and try to remind the stakeholders of their critical responsibility in the financing of WASH. And we'll continue gathering when we have an opportunity. I think yesterday we were together, sir, with the Honorable Cyrus. We were together again somewhere, and today we are here, and from here we are also moving somewhere. We want to continue talking to our people about WASH. So thank you, our Engineers Without Borders. Allow me also to appreciate the PNFPs for the services that they have been providing to our people. I think we need to agree that more than 40% of the services in this country are provided by PNFPs. And actually, at one point, there was a worry that the PNFPs were, I don't know whether that was a worry, were actually taking over the healthcare system, because majority of our people had found that it was more reliable to visit the PNFPs than going to our public facilities. And that is the picture we are trying to work on and to change. So thank you, was it Dr. Hillary? Yeah, for that presentation. Was a good one. Although when you're talking about the billions, I wanted to look out at the contribution out of the billions, the contribution that the PNFPs have given to WASH. That is very critical for us because we really must improve WASH. It's not a choice, but it's something that we must do. And I want us to agree here, like it is spelled out in the Uganda National Minimum Healthcare Package. WASH is one of those critical components in there. I think it is either number 4 or number 3. But also in the health sector strategic documents, WASH is number 1. I don't know whether you've interacted with some of these documents, including the National Health Policy. WASH is number 1. The focus, the ministry says, in the next 10 years, we shall focus 1, priorities, and about 4 or 5. But WASH, health promotion, prevention, water, and then immunization. It's there. It's there. So I want us to agree that since it's a critical component, we should be able to appreciate that it requires focus in terms of investment, but also commitment as a government. And I want to emphasize that there is no doubt that improved WASH in healthcare facilities has a direct contribution to service uptake. That one, even my mother in the village knows. She won't go to a facility where, for example, a latrine structure is soiled and she will not be able to use it. She will not go to a facility where, for example, the floor is so dirty, and so they know these things. That's why I said they had resorted to moving to the PNFPs, because as far as we know, the PNFPs have actually tried to put time and invest in this area. So, as this is a message that people who operate our public facilities must really understand. So there is no way you'll talk about increased uptake. For example, for maternal services, Dr. Hilary has given here, I was trying to create a correlation between improved maternal services and so you will not talk about improved maternal services when you're not actually addressing issues of WASH. In fact, we have to say that without WASH, there's no improved care. That is a fact. And of course, for us who are in the medical field, we agree that some of the issues that we get, especially in our maternity wards, the postnatal issues are actually related to infections that result from WASH, abscesses, sepsis, all those things. This is related to WASH. So we can't talk about improved quality when there is no. So there is clear evidence that poor hygiene in healthcare facilities is the leading cause of mortality and among mothers in our maternities, but also a leading cause of mortality and morbidity among children in our communities. And we've also done studies. UNICEF has done a lot of studies. I don't know why Borders, you didn't invite them. They have done studies, and one of the studies has indicated that there is a direct correlation between improvement in nutrition and when WASH services are well provided. When you reduce open defecation and provide safe water, you reduce stuntedness. Is it stuntedness or stuntedness? I don't know. I think this depends on the school you went to. So we want to say WASH is really very critical. But again, on the other hand, it is very unfortunate that WASH is one of those neglected issues that we do actually forget about. And therefore, I've actually noted when I moved to facilities that majority of our healthcare facilities actually have very limited WASH services. You'll even be surprised to reach a facility and there's only one toilet facility for the staff, and there's nothing that has been provided for the patients. Or the one that has been provided is so much soiled that it can't be used by anyone. So in that form, we say these facilities have limited services. But one of the most hit indicators here is hand washing. I'm surprised that Honorable Cyrus was surprised that hand washing is actually, it is one of the most, even with COVID. Yeah, COVID has been here and has indicated that hand washing is a critical issue, but it's one of the areas that is not actually performing well. So therefore, WASH interventions should be put in place and are required to address gaps identified in healthcare facilities. I think that is very key, and therefore we should come up with clear interventions to be able to address these gaps. And lastly, I would say financing challenges and investment in the area of WASH. Yes, there is an effort for us to support WASH by providing 30% of our APHC allocations to WASH and the other conditions that are related to health promotion. But our people do not actually observe some of the guidelines that have been provided. You go to a healthcare facility and not even a single % is provided for these services. So with There is a study that has been done by our colleague from the Uganda Sanitation for Hygiene activity that highlights the importance of that highlights the gap in PHC remissions. I think it is one of the studies that I've seen in this country. There was also another one, I think, by Plan, I don't know, Plan, that was done together with CESBAG. PHC, 30% of the PHC allocation should be able to go to health promotion, disease prevention, and WASH. But this is not the issue. It doesn't happen, and therefore, we keep complaining. It is very common that you give out this money and people say, we have bought medical supplies, we have bought soap. No, 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 that money is actually intended to advocate for WASH. With these few remarks, I was asked, I thought I should say something, since I'm a caretaker of some of the things. Yes, allow me humbly to invite the guest of honor, who is representing the State Minister for General Duties, Honorable Hanifa Kawoya. I know you have a lot of passion, sir, for public health issues. I humbly request you to come and make your opening remarks and officially open this meeting. And we are privileged to have you here, sir. I know you were very, very busy. Since morning, you've been receiving calls, and we've also discussed that you have another meeting. Thank you very much, sir, for honoring our invitation.
I start by extending my apologies. I walked in when the meeting had started. I apologize for coming very late, but also before being delegated to represent the minister, I had been having a responsibility to receive donations to our nutrition program, so I had to honor that meeting. Also, I need to apologize. I decided to leave because I have another meeting which is already started, and I told them I'll be here for 30 minutes. And my colleague was going on beyond the time, so I'd preferred that I would step out and I'll send my speech later. The apologies are out of the way. Ladies and gentlemen, thank you for coming for this very important meeting. Thank you for inviting the Minister of Health. Our Honorable Minister has not been able to make it because, as you know, she's now in the district somewhere. She duly received her invitation and passed it on to our office. My name is Dr. Daniel Chabainze. I'm the director in charge of public health, but I'm also the National COVID-19 Vaccination Commander, a docket where I upload all Ugandans that we've done very well. Thank you for keeping on your masks, and thank you for getting vaccinated. I am also a researcher, so I am very keen in receiving research messages. Before I give the minister's speech, allow me to note that in the presentation of Dr. Hillary, we noted the number of health facilities, the few corrections that need to be made in how many else the government has, but at least he concentrated on what the private have. I also wanted to make a comment on the Member of Parliament. We mentioned that majority of the money for Ministry of Health stays at the center. That was not correct and accurate, and I would be happy to correct when I have a chance to meet him, because Parliament appropriates money and it's all public knowledge. What the money does, where it goes. The center only has just a wage bill for the commissioners. Nothing stays at the center. So it's for only coordination and governance. But finally, I also wanted to say it's important for us to think about the national insurance scheme. For us to go forward as a nation and for people to have resources to meet the high out-of-pocket expenses, we must have a system which protects everybody from catastrophic expenditures due to health. I felt these were not part of the minister's talking points, yet they are key to what we are saying. And I finally want to say, after you've made the presentation here, I'm going to give an invitation that you come to the Senior Management Ministry of Health and make the same presentation so that the policymakers have a chance to appreciate. When I take the book and the presentation, very few people will submit. But if you can give us 15 minutes of your presentation time, it makes a lot of weight. So in our next meeting, I pledge to make sure we put in a slot to invite you and speak to senior management where all the commissioners sit, and we are able to digest your results. This is the speech as provided by the minister. Now allow me to speak in her capacity. Our development partners, commissioners from Ministry of Health, commissioners from Environment, Water and Environment, senior officers from the different parent ministries, our implementing partners, development partners who have funded Engineers Without Borders. Ladies and gentlemen, I take this honor to welcome you to this meeting and officially open this workshop in which findings of the WASH in health care facilities from circulated PNFPs shall be presented. The Ministry of Health is committed to improving WASH in the healthcare facilities because of the associated benefits that include it contributes to improved quality and safety of healthcare, reducing infections and associated complications, associated mortality, improved occupational health, staff morale and performance, and increase in trust in healthcare services. Inadequate WASH services in the healthcare facilities have discouraged women from giving birth in health facilities and may be a cause of delay in seeking care. Health facilities that have poor water, sanitation, and hygiene practices are likely to contributing reason why many people choose to stay at home and even have deliveries outside the designated areas. We've already heard that there have been other studies which have been done, including those of Ministry of Health. The recent WASH in health facilities conducted by the Ministry of Health indicates that there are still gaps. As we commission, therefore, as a commissioner and other health officials will make different presentations here, we request that we understand the information and use it to answer the gaps. I have already read in the book the recommendations presented forward, and also on behalf of the minister extended an invitation for this presentation to be made in our committees at the Ministry of Health. I therefore call upon all like-minded implementing partners and our donors and funders to support government in the effort to improve WASH in health facilities. I therefore declare this workshop officially open for God and my country. Honorable Anifa Kawoya, Minister for State for Health Work. Thank you very much. So you will allow me to speak to the media and then thereafter take leave for the meeting. I'll be able also to receive the proceedings of the meeting. Thank you very much.
Wow, thank you very much, our guest of honor. The commitment alone is heartening. We know where to start from. And with the invitation to present this to senior management, I believe we're on the right track. Ladies and gentlemen, you've been enjoying starters. Now it's time for real meat. I want to bring you the team that was at the helm of all this. Dr. Peter and others had to fold their sleeves to go in depth to find out the state of things in our healthcare facilities. WASH on top of their minds, and he's here to share with us some of the key discoveries. Ladies and gentlemen, if you feel a little fatigued, you can stand up, stretch a bit, sit down, or sirike. Engineer Peter, may I invite you to come and present to us the key findings.
Thank you, Simon. Our moderator. Maybe just to clarify, I'm an engineer, not a doctor. I think Simon called me a doctor probably because I was going to make a presentation in the healthcare facilities. The guest of honor in his absence, the commissioners, the Commissioner Epitu, Commissioner Moses, the other government representatives, the chief administrative officers who are here, the district health officers who are here, our colleagues from UCMB, UPMB, PES Uganda, my colleague from the USA, our chief engineer based in the USA, our colleagues who are online. Allow me to welcome you to this presentation to present our findings in the WASH in healthcare facilities. So before I begin the presentation, the assessment was conducted by Engineers Without Borders in close coordination with the Ministry of Health, the district health officers in our partnership with UCMB, UPMB, and PES Uganda. I'll go right into the presentation. My name is Peter Nzabanita, and I'm the Country Director for Engineers Without Borders USA, the Uganda country office. And I am presenting the findings on behalf of UCMB, UPMB, PES Uganda, and Engineers Without Borders, and as I indicated, in coordination with the Ministry of Health. Engineers Without Borders is an international organization that works globally in about 38 countries, and with engineers who are chapters and also volunteers. And you have two programs, mainly the International Community Program and the consulting program. Next, please. And we provide services in agriculture, and irrigation. We are involved in the disaster risk response, renewable energy, civil and infrastructure, and WASH, for which we are here today. I will begin by borrowing these important words from Dr. Naylor of WHO, that a healthcare facility without WASH is not a healthcare facility. And I think this has already been demonstrated by the previous speakers. Our presentation, our findings are aligned to the two SDGs, SDG number 3 for health and SDG number 6, and which all geared at ensuring that WASH services are very critical, but also if not provided for all people, then we'll not be able to achieve them, the SDG, the 17 SDGs in total. So without WASH in healthcare facilities, Uganda, like any other low development countries, will not be able to achieve the SDGs, and specifically SDG number 3 and SDG number 6. In 2018, the UN Secretary General called for a wash action in healthcare facility because of its importance in prevention and safety of the people who utilize those facilities. And EWBUSA, like USMB and other organizations were committed to this global call. And specifically, there was another advocacy group which was started in 2020, which was Global Water 2020, and it had a 3-year period. In this period, Engineers Without Borders and UCMB, I think AMREF and other organizations in Uganda committed to this initiative. And this is where we have, where we began our journey to get out to the WASH in healthcare facility challenge. Our role is provide technical support, assistance in implementation of WASH in healthcare facilities. And we have so far demonstrated some work in some of the healthcare facilities as we just go and look as we move ahead in Busia and in Ilundu. The assessment for WASH in healthcare facilities was to establish the WASH service levels in the PNFP healthcare facilities, to identify the challenges deterring the improvement of WASH in healthcare facilities. I'm glad some of them have been mentioned already. To generate data for WASH in healthcare facilities, very important because without data, you're not able to improve anything in healthcare facility systems. And to advocate for increased investments and partnerships in WASH in healthcare facilities. This is very important for us because we think we cannot do it alone. Government may not be able to do it alone. It's very important, as probably my colleague might have highlighted already, that EWBSA, in partnership with the corporate organizations in the US, have been able to support some of these actions, including this presentation that we are making today. So the scope of the study that we conducted was in 54 healthcare facilities that fall or that are under the management of Uganda Catholic Medical Bureau and Uganda Protestant Medical Bureau. We did not visit the Uganda Muslim Medical Bureau because we are still trying to establish a relationship with them. The technical assessment was conducted by Engineers Without Borders and PACE Uganda. And the study was conducted in Eastern Uganda, Karamoja, Central, West Nile, and Northern regions of the country. This effort follows our other study that was conducted by Engineers Without Borders with funding from World Bank that was focused on institutional WASH, which covered 250 institutions in the country. Those were majorly public institutions. And these included 115 healthcare facilities and 135 schools. From the master list of 2018, we have about 6,937 healthcare facilities and special clinics in 128. I'm sure this has been updated, so don't mind the numbers. So in terms of the percentage by ownership, I'm glad also that has already been distributed and well explained by Dr. Hilary from UPMB. But those are the numbers. That's the breakdown in terms of the distribution of the ownership of the healthcare facilities. Breaking down the healthcare facilities that were visited, of the 54, 63% are UCMB managed, and 37 are UPMB managed. This is because the assessment was done in a two-phased approach. And the first phase, at the first phase, we had an MOU with UCMB, and in the second phase is when we established an MOU with UPMB. So that's why you have the difference in numbers, in percentages. And 20% are health center 2s, 63 are health center 3s, 2% health center 4s, and 15% are hospitals. In a data collection process, Engineers Without Borders and Feed the Hungry in the past 3-4 years have been involved with WHO and UNICEF and other partners to develop a wash fit tool. And this is the tool, the globally accepted tool that was deployed in a collection of this data. So the data provides information on scores on basic, limited, and no service. And it covers issues to do with water service level, sanitation service level, hygiene, management at the workplace, that's including the management of the water service systems, and environmental cleaning, energy, and health care waste. So the presentation covers all these aspects within the healthcare facility systems. I will try to probably maybe talk more a little about the water service later. And they have a safely managed drinking water service. So when you talk about, I think we've talked about the basic, the limited and unimproved, or probably no service at all. So those are just the descriptions that indicate the meaning. In case we talk about a basic service, we are talking about a drinking water service from an improved source, provided correction time is not more than 30 minutes. So in this case, sometimes you have the source at the premise, not necessarily connected to the critical departments of the healthcare facilities. Next, please. A summary of the findings. Of the 54% of the 54 healthcare facilities, 61.4% had basic water service. So water is available or near the healthcare facility. 20.1% had limited service. So they have to chew for more than 30%, and the service is not necessarily within the premise of the healthcare facility. Probably maybe to correct more is that the 61.4% does not necessarily mean that water is actually reaching where it is supposed to be. I think that's very important. 18.5% do not have water at all. In terms of sanitation, 69.5% had limited service. 69.5% had limited service. So in sanitation, we did not have a significant number of healthcare facilities with basic service. Sanitation is the most critically affected component in the assessment. Most of the facilities have shared latrines, poor quality latrines, and in some places they are probably not there, or the standards are, I would say, are not acceptable. In terms of hygiene, our figure probably concurs with the Ministry of Health, which is it's closer. We saw 51% of the healthcare facilities with basic hygiene, and this is probably attributed to the COVID-19. 48.2 had limited service. In terms of environmental cleaning, only 5% had basic environmental cleaning services. Environmental cleaning services seems not to be a good area. I mean, in terms of the investment by the health facilities, and that's why we had a figure of only 5% with basic services. In terms of energy service, so we're looking at also at energy provision, energy availability to ensure that the facility are able to run, are able to store the medicines, the vaccinations well, but they're also able to have light when they need it. And I think probably building on what the director just said, also to keep some of the staff within these institutions. So 62.9% had access to power. However, this power is unreliable. The power was found to be unreliable, especially the national grid. 34.1% had limited power, and 5% had no power. So in some places, I think in the eastern region and somewhere in the northern, we were informed that they still perform some of the deliveries using the torches, the phone torches. Next, please. In terms, I know operation and maintenance of WASH facilities is still an issue, not only for WASH in healthcare facilities, probably a national issue, but from our assessment, 12% of the healthcare facilities reported a sufficient budget. Budgets, I think there's been some money that has dropped in the UPMB and UCMB. I hope that will probably, some of it will go into that docket. But the budget for operation and maintenance is a very big challenge. However, very important to note also, it's also important to note that it's also related to the issues of availability of the capacities within some of the regions, especially Karamoja region. We also try to find out if there is a focal point or focal persons for WASH. We know there's IPC focal persons, but who are not necessarily trained on WASH issues. So 54% of the healthcare facilities had no dedicated WASH focal point. And we had already mentioned some progress in hand wash in hygiene, but we want also to be clear that in HCFs, the healthcare facilities, all the healthcare facilities that we visited, the hand, less than 75% of the hand washing stations were seen at the points of care, and we're not seen to be functional. Please go back. Yeah, regarding the healthcare waste management, 31.6% had basic waste management service. There is some level of management of waste management. We're able to see some coded bins in some areas, or probably also some level of collection. And we also, in some areas, also able to see some sort of like disposal of this waste. Yeah, we have some good news. Some good news has already been highlighted in some of the findings, that 61.4% of the healthcare facilities had some basic water service. And as I already indicated, basic service does not necessarily mean that water is where it is supposed to be. 69, at least there's some percent, 69.5% have some sanitation service, in these healthcare facilities, 54 of them, 62.9% have access to electricity. And one thing that is also very important to mention here is that the Ministry of Health has developed WASH in healthcare national standards. I saw the Commissioner for Environmental Health with the document, and so I think it will be very helpful. And they developed that document with support from UNICEF and WaterAid. So we acknowledge the partners that have also provided that kind of support. And probably, maybe some of the partners here will be able to take advantage, take this document if it is available from the Ministry of Health. So we noticed that there's some level of improved infrastructure, and there's good connection with the district health office amidst the challenges. And that's why we have some of the chief administrative officers here and the DHO's representatives here, and some online. And very clear, it was very easy to see hand wash stations in most of these healthcare facilities. It was also easy, I think, as also you've seen from the presentation by Hilary, there's some level of improvement of infrastructure. I may not be able to say the source of funding, but the funding are probably external funding. Next. And again, that's a continuation of the improvement. I talked about the bins, I talked about the latrines and some level of insulation at some of these healthcare facilities. On the other hand, there is still a lot of work to be done, and it may not be possible to be done by only us, again, by the government, the Minister of Water and Minister of Health, but we need everybody. So we noticed some inadequacy in water provision and reliability, especially in areas where there are utilities. We found that the power is a problem, and sometimes the water is probably insufficient. So there is a challenge between the demand and the supply in terms of water in some of the areas. I think there are also some bit of challenges with hand washing stations, depending on the level of people and the trainings of people. And in many instances, we did not find soap and sanitizers around hand washing facilities. We know that there are challenges now with the economy, but unfortunately, I think the research was done before we had these challenges. So we hope this is an area that would also be able to improve. I think you can see the quality of water in one of the photos that is coming through a tap, and some of the hand washing stations. Next, please. Yeah. You notice the quality of some of the sanitation infrastructure in some of these healthcare facilities. If you look at the photos, the photo on the left is I would say I would call it a waterborne toilet, but it's dilapidated but still in use. And you can see in the middle circle that is a bath shelter. And then you see the other one is also a 3-stance a pit latrine. And then in the below circle, you see that is an incinerator. We found so many different and difficult to explain types of incinerators. It was very hard for us to draw some lessons from some. But of course, there was an incinerator which we saw in Kasese, I think, Kasese Health Center 4 in town. That was really very good. That would be a good study problem maybe for the partners that might want to learn a thing or two about maybe the better incinerators, much as we have some of them recommended in the standards. So that is an incinerator, and you cannot tell the efficiency. So it's one thing that is very important, I think, is to do some research on the efficiency of some of the different types of incinerators that we have in this country. And then, as you can see, we have open waste disposal. From the healthcare facility, you see we are collecting waste from the coded bins. But when it comes to disposal, the disposal is uniform, is joint, and it's a very big challenge to the environment. It's a very big challenge to the water that we need. It's also a very big challenge it contributes probably to the climate change and to the disease that we may not be able to treat. Next, please. We wanted also to bring to your notice that much as we have talked about all this infrastructure in terms of WASH, in some of the healthcare facilities, the existing infrastructure is very dilapidated, and it's deteriorated, and it becomes very hard to even install a water system if you have to extend water in such a structure. It's very hard to, you can't be sure if you'll be able to climb maybe on the roof to install a solar panel and maybe you come safe. And you cannot take advantage of the, maybe of rainwater harvest system. And definitely, most of these healthcare facilities need probably maybe some funding support from the other partners. Next. I think this has been discussed, but we want to stress it again, that in the past, there was a tendency for the planning and budgeting allocations, including for some of the organizations in the NGO world that fund WASH and health aspects. There has been more investment in the treatment than prevention, and yet we know that prevention. I think there is a saying that prevention is what? Yeah. So we know prevention saves lives treatment saves lives in a short run, but probably you'll get treated and you will take dirty water again. You have typhoid in the next few minutes. So yet prevention would save resources, including the finances. Would save time and of course would increase people's participation in economic development. So we appeal that such prevention-oriented programs, such as WASH, are areas where partners should invest, including the corporate organizations that may be here or may be listening to us. As I mentioned, our colleagues from the US have been mobilizing some of the resources from the corporate organizations to respond to WASH in healthcare facilities, to support the WASH actors, to support government in improving this. So if there are any organizations, corporate organizations here or listening to us, I think it's something that they need to think about. Next. So what next? Yeah, so we want to thank the Minister of Health and the Minister of Water for taking lead in developing standards. And they want to encourage the ministry and partners who are able to go out there and disseminate these standards. So we think that, yes, we have had the standards developed. It's very important to disseminate them. But it's also very important that the Minister of Health, I think there's some from the Commissioner's speech, we need to develop a roadmap to WASH improvement and and integrate it in our planning and budgeting. This data is very important, and this information in some areas where we've had more time, we have discussed it with some of the health unit management, including Ilundu and Daban Healthcare Facility. And we hope that they will be able to improve their planning and budgeting. It's something that we think that the Ministry of Health should take lead on. And it's very important also that a uniform data-based monitoring system is developed to evaluate progress. I think there's a lot that is probably being done within the healthcare facility improvement that is not probably monitored, that is also a little bit probably, the approaches are a little bit different. So it's also very important that we enhance capacity building. As I indicated, the recent wash fit developed by WHO and UNICEF is available, and Engineers Without Borders has the capacity to do the training, but of course we're limited with the resources. And so it's a very important tool that we realize that even at healthcare facility level, they can be able to assess the situation, they can be able to improve their planning and also the budgeting. So it's a very important tool that we might find ourselves investing in. Coordination. The Honorable MP, I think, hinted about it. It's very important to have a coordination of this information. It's very important for the Minister of Water, Minister of Health, to know what is happening and the approaches, and I think how these can be improved. But also engaging the district local governments and the politicians. I think in the midterm review workshops that have been held in the past few days, the government, through the National Planning Authority, is encouraging reviewing our approaches and incorporating them into the parish development model approach. I'm sure Commissioner Epit would be able to speak more authoritatively on that. But it's very important to look at how the parish development model can also be helpful in this area, especially in coordination, but also in the management of some of these infrastructure. Yes, enhance coordinated advocacy and fundraising. Our colleague from the Ministry of Health has already informed us that yes, we are, as a government, the Ministries of Health, Ministry of Water and Environment, and Engineers Without Borders, PACE, and others may not be able to do it, but we must be coordinated in our advocacy. We must make sure that we are sending probably the same message across, and we must seek for resources. And these resources, of course, can only be mobilized when we have sort of costed roadmaps from the Ministry of Health. And then we also want to encourage all of us, the partners and everybody listening to us, that in Uganda, the Ministry of Health, with support from UNICEF and WaterAid, a national washing healthcare facility standards was developed. And it's very important that this is considered for adoption and implementation, especially in areas where we have identified gaps. And then it's one of our other last recommendations is to develop models or to do more research in what works, especially in scaling models that improve and maintain infrastructure in healthcare facilities. And we can all do better. And through an advocacy like this, in WASH and beyond WASH. Beyond WASH, I mean, the media has to be involved. the media has to support, the media has to send this information. We need to have the involvement of other partners that are not the traditional WASH actors to support, direct some resources to the rehabilitation, replacement and improvement of WASH services in these healthcare facilities. Of course, in line with the national standards, but also to make sure that we are able to achieve the national set standards and SDGs. And then enhance operation and maintenance capacity building, that's very critical. And very important, enhance data collection and monitoring in WASH and HCF to help the Ministry of Water, Ministry of Health to coordinate, but also to report accordingly. Yeah, so the big question is, WASH in healthcare facilities, everyone's responsibility. What are you doing about it? So we want to acknowledge the following partners that we are able to learn who are doing some work in WASH in healthcare facilities. UNICEF and WaterAid, as I already mentioned, have developed some standards. And they actually developed, UNICEF and WHO also developed 8 practical steps to improve WASH in healthcare facilities. World Vision Uganda, IRC are doing some work in Kabarole, GPEGO, WaterAid, Water for People, UNHCR in refugees, and AMREF, and others that we may not have included here. Of course, not forgetting the work that's been done by our partners, PACE, UCMB, and UPMB amidst the resources that are not available, but managing to raise the WASH, the water service provision to 61.4% is not easy. And finally, we want to thank our supporters, our donors who have funded our past studies. That's the World Bank, the Uganda Group, Fairview Foundation, and the Wallace Genetic Foundation. I thank you.
Wow, some work here. Thank you very much, Peter. I called you doctor on purpose, and I've got no apologies about that because you are very scientific in the way you approached everything. You diagnosed and treated, and then created lasting solutions. Engineer Peter deserves another round of applause, ladies and gentlemen. And right now, I'm opening the discussion to the floor. I would encourage our virtual audience out there to share with us their thoughts. We'll be very glad to read out some of your opinion and what you really think must be done. One on part of advocacy and the practical areas that we need to tackle to address the WASH challenges. There have been quite several, as highlighted in the report or in the findings by Engineers Without Borders. Let our conversation equally have no borders, but be restricted within time. We are going to invite a number of panelists who are going to share with us their opinion. But before we get into panelists to discuss resolutions, I'm going to pass the mic around. There have been quite a number of presentations that have been made. Some have been in forms of commitments, others have been in forms of questions, and probably, I believe, you two would have something to add. So please raise your hand. I'm going to entertain 5 Peter, is 5 enough? 5. I'll have 5 contributions. Please be as brief. Introduce yourself. Share with us what you think. Father Katabas, do I start with you?
I just have one thought after listening to the many presentations we have had. I have been involved in coordination of medical services for some time, more than 15 years. And we have always asked ourselves, why is it that we fail to meet the standards in relation to WASH? And I got too many reasons. One is attitude. And the second one is actually an issue of prioritizing issues. In the health facilities, people always look at how do we survive as a unit. They have 2 things in mind always. How do we pay our staff and where do we get the medicine? As long as they get medicine and the staffing, the rest can follow because the unit can still continue. So as we look for a solution to this, we need also to address the issue of health financing, which is a very big issue at the PNFPs. Thank you so much.
I hope someone is capturing this, right? Someone at the Secretariat is taking these ideas. Okay.
Father Natoli Varikowa from Wirundu Health Center 3, St. Matia Mulumba. Gerard mentioned the coordination and collaboration. Very important. It is this collaboration that actually put us in connection with Engineers Without Borders. I could say they came as Abraham had 2 visitors, strange visitors, and he welcomed them. And there they promised him, next year when we come back, you will be having a child with Sarah. For us, we welcome these Engineers Without Borders, not knowing what they were coming to do. But what came out of them is good news for our health center. WASH is very sensitive and very necessary, but again, very expensive to maintain. It is not easy to maintain these WASH targets. But we have been helped by Engineers Without Borders to actually prioritize and handle this sensitive issue, which is necessary and we cannot do without. So I would like to also mark that it is very expensive, even in parishes. Perhaps we are trying to maintain these facilities, but you find it very expensive. So sometimes people neglect them, not because they don't want, but because they are very expensive. Thank you very much.
Thank you very much, Father. When you stand up, please introduce your full name so that the Secretariat can capture your opinion.
Thank you, Simon. My name is Paul Oyesuje, and I'm the WASH Country Program Manager at World Vision, Uganda. I just want to thank Engineers Without Borders and partners for bringing out this research and bringing us together to discuss these issues. But one most important is to see religious leaders involved in this discussion. Issues of behavior change and attitude. Religious leaders and cultural leaders actually play a very critical and vital role. And we appreciate to see in this kind of conversation having religious leaders part. When you look at 5 years ago, the issue of WASH in healthcare was lying, there was no clear ownership. It was neither being addressed by the sector Ministry of Water and also in the Ministry of Health. But we are glad to see that right now, every conversation that is going in line of WASH, both the ministries are actually involved. And we want to thank the government for taking this leading role on integration. These issues that Engineers Without Borders and partners today shared are indeed critical. And if we are going to move forward towards addressing the issues of universal WASH access and universal health by 2030, then this kind of integration is going to be critical. And as one of our colleagues shared, it is our prayer that the ongoing enforcement and support towards the parish development model, these basic requirements, especially for a basic household, if we look at even at a household, a basic requirement, having a latrine at home can be one of the standards that we can look at. As we are, I think in next week, around 5th July, we shall be again disseminating, UNICEF and Ministry of Health will be disseminating the standards on WASH in healthcare facility. And probably that will help us to cause alignment across all the partners that are implementing in health facility. And again, we cannot address it as individually, but at least we can have a journey that if Engineers Without Border is able to put a water facility, then PES can come with an incinerator. World Vision can provide maybe a waste bins, and then IDI will do IPC, and then the ministry will provide a mentorship. And at the end of the day, we can actually comprehensively intervene and sustain the intervention in health facilities. So once again, I want to thank the team that organized this dissemination and also that supported the research. Thank you.
Well, thank you very much. Very interesting views. I want to recognize in the same vein, Mr. Emmanuel Inebiona. Sometimes I mistake you for a doctor. He's the spokesperson of the Ministry of Health. So your presence alone is a demonstration that the ministry is in agreement with the kind of work that Engineers Without Borders, PACE, and other partners are doing.
Thank you, moderator and colleagues. My name is Peter Anyumiza, and I'm here representing PACE. I want to quote one of the great biostatisticians who said that without data, you are another person with an opinion. So I really want to appreciate the team that has come up with this data. It was one of our objectives to generate data that we can use for basically to showcase the problem, the situation in health facilities, and basically advocate for these services. And I want particularly to speak about the behavioral change. He actually alluded to it. We have seen this in not only in facilities, but even in our homes, in our communities, how people really take WASH issues so lightly. It was only until COVID that people became a little bit vigilant. But again, if you go to make an assessment, the investment that was made during COVID, you know, there's a lot of facility that was put at entrances of marketplaces, in busy places, in supermarkets. You hardly find anything. If someone was to make an assessment right now, how do people perceive these things? How do people perceive WASH, the importance of WASH, even in our communities? It is really, really a very big gap. So as we work around fixing the hardware, providing water, I think one of our key role is to really support our communities to change their mindset, to know that, you know, it's not good to waste water. You go to a facility and you find water just running as it's for free. A tap is broken and basically there is there's no intention of keeping these things that have been given to communities. So we'll be working together with the teams and partners to make sure that we advocate for this behavioral change. People can know that WASH is important. But lastly, I want to speak to the person who's most affected, the mother and the newborn. If you go to these facilities, you know, I've had the opportunity to visit so many facilities across the country, and you see how mothers and newborns can suffer. You find mothers bathing outside the bathroom because they're going for labor, they're going for delivery, they're going to, but they don't have privacy, they don't have enough facilities for themselves. So really, mine is just a little bit of an encouragement that we can do something, and we can do it together. Thank you. Peter Nyumiza from PES.
Thank you very much, Peter. I'll take two more. In the name of gender, let me move to the lady. When I said 10 hands were raised.
Thank you so much, Engineer Peter, for the presentation. Thank you, members. My name is Namia Aloket. I work with the Ministry of Water and Environment. Mine are just brief. First, to emphasize what Peter has talked about, the issues of water, sanitation, and hygiene are very appalling, not only in healthcare facilities, but also in the communities we work in. So as some of the roadmaps are being drawn, we need to emphasize mainly on budgets, especially when it comes to healthcare facilities. Those we have visited, you go there, they tell you that the budget which goes to the operation and maintenance, the replenishing of the items that are needed to practice proper sanitation and hygiene is still very low. And on top of that, my colleague Paul from World Vision has mentioned it, we need to stop doing business as usual, calling us only the technocrats. I'm happy that we have also the religious representatives, but we should also have cultural institutions invited for such dissemination, such workshops, because they talk to their, what are they called, their people, to their subject. So it will be important for the next disseminations we have cultural representatives in place to also take up the message and also maybe support the initiative of promoting water, sanitation, and hygiene in healthcare facilities. And also another partner that we shouldn't forget in all this is media. Peter here, Simon said he put something on Twitter and he got many comments coming. Media does a lot when it comes to advocating for proper wash in communities, in healthcare facilities, everywhere. So we should encourage them to report properly on wash issues and also to give them that that energy boost. Energy boost I'm talking about is the trainings and also inviting them for such activities. There they will put us government on spot, and there we shall be promoting good governance. And the issue of integration is also key. Integration, collaboration, coordination. Yes, when you talk about water, sanitation and hygiene, Ministry of Water comes into play where I work. Ministry of Health comes into play. And also other partners. So we should integrate these activities that we do in the communities. For example, as Ministry of Water and Environment, when we go to provide water, we'll not say that we are leaving out this healthcare facility. We, in fact, encourage within the project areas where we work to provide water to institutions such as healthcare facilities, as well as schools. So the integration part is really key. When we go there as water, we'll provide the water and also do many sensitizations regarding promotion of good sanitation and hygiene practices. And lastly is the issue of the guidelines that have been developed by UNICEF and WaterAid. I would encourage that they are disseminated not only at national level, but also the districts and the sub-counties where these healthcare facilities are found, so that the message trickles down to the people we want it to go to. Thank you so much.
Well, thank you very much. Very interesting observations. Now, I have a soft spot for mothers, but time. Will you speak in a minute? You're not sure? Okay. I surrender.
Good afternoon. Thank you so much, Peter, for the presentation. And I think I would want to encourage the political leaders, that is political involvement, and also the stakeholders. I would want to appeal to everyone who is here, who has been honored to be here. And when you go back to the community, you look at political involvement and the power the political team has, the honorables in the House, and those that may be left. Sometimes you go to the community, and when they speak, when they're looking for votes, when they say it is not good for you not to have a latrine in your place, and it encourages them, and they know. And sometimes they voice out there. You know, when they hear there is now water in Dabani Hospital, and a politician comes and says, now you go and get the water, it is free of charge. And you know, the community comes, somebody reaches the facility and says, my honorable told me that he brought water and it is free of charge. So like someone has said, whether I opened the tap and it runs from wherever it is for the whole day, it is okay. So I'm just appealing, please, politicians, let's try. All the stakeholders have had World Vision, very pertinent partners that we have. And I would want to still request, come on board, get to know the information, get to know about what engineers Without Borders did in Dabani, what triggered them, and what is our priority as a facility. And of course, for us who have benefited, I think the partners normally look for sustainability, and we are geared to that. And PNFPs, you will not miss that bit of sustainability. Thank you so much.
Well, thank you very much. Finally, before I read some of the comments that come from our virtual audience.
Thank you so much for the opportunity. Some of the issues that they have raised, but I wanted to talk about the issue of the quality. Whatever we have, when I look at some of our facilities, we have some toilets which have lasted for more than 20 years. But these days, you can find a toilet which they have constructed like after 2 years or 2 years ago, but it can no longer work. So we need also to emphasize that. Secondly, it's about repairing. We still have a problem. We have just discussed with my colleague here. There are some small things, but when our managers cannot repair, it's really hurting. Lastly, it's about maintenance. You know, it's really very, very key. Someone has just talked about sustaining. We may have these projects. You may have a water tank. You may have something that's really very important, but maintaining what you have been given is really very key. I think we need to teach our people, we need to help our people, first of all, to appreciate what we receive. And these days, Father Katavaz always tells us that it's not easy to lobby, to get funds. But once you get something, how are you going to maintain what you have received? So our engineers, we thank you so much. But one of the things we need to put emphasis at is really to see how we are going to help our people maintaining what we receive and also repairing and sustaining, as they have already mentioned. Thank you so much.
Well, thank you very much. Like I intimated earlier, we have a virtual audience. There are quite a number of people who've been enthusiastically following what has been happening, and we want to engage some of them to share. I will have one or two Yes. Your name and where you're watching us from, please. Things over IT. I studied the arts. Is the volume on? She's not speaking. Oh. She's called? Jen. Hi, Jen. Can we hear you, please?
Oh, okay.
Yes, we can. Sure.
Okay, thank you. Thank you very much, Simon. Thank you for the moderation. And thank you, Engineers Without Borders USA, for the invitation. I love the topic. I'm passionate about washing healthcare facilities and the work that all of us are doing in that area. I have one question and probably two comments, if you would allow me. The question is specifically on the costs. I think there was in the presentation, or somebody mentioned earlier, that, yeah, there are high costs. I think it would be of benefit to all of us to know how much of that actually goes to water, sanitation, and hygiene in real terms. So that, you know, in terms of planning, in terms of budgeting, we know exactly that if it's a health center 3, health center 2, health center 4, we know how much exactly we should plan for water, specifically, and what aspects of water. For sanitation, what aspects of sanitation? These are all block terms, but in there are details. How much you go to hygiene in practical terms. Then to my quick comments, the findings are really adding on to quite a pool of work that is being done by many others. I work for IRC International Water and Sanitation Center, and we do our work in Bunyangabo and Kabarole districts, and we coordinate and collaborate with Water for People that does work, washing healthcare facilities work district and in Luuka district. We've contributed through, you know, providing incinerators, and it's not cheap, doing waste management, providing water itself, safe water, working with National Water and Sewage Corporation and the Midwest and umbrella to connect water to the facilities. Very, very keen on the connections, really going to what we call the hotspots. Which are the hotspots in a healthcare facility? I think we should look at that. It's not just about saying, oh, we've connected water to a facility, but look at the hotspots, the maternity ward, the labor ward, the children's ward. If it is a healthcare facility that is high volume and it's near a highway with so many accidents, if you look at Kawolo Hospital, for example, so many accidents in a day, in a week, where are the water connections? Where are the water points? Where are the sanitation facilities? Where should they be? You go to such healthcare facilities with high volume near highways, and it's not there, or they've put the connection very far. You know, there's no water in the maternity ward. I think we need to look at the hotspots in the facility. Secondly, there are organizations that have done quite a lot of work, as I said. The School of Public Health in Makerere, working with Emory University, they've collected a lot of data. They've done quite a number of studies. I think we need to connect with them. The Centers for Disease Control and Prevention, Infectious Diseases Institute, and many others, many organizations really doing this work, and they've collected data. Probably the Ministry of Health needs to come in more strongly to coordinate all of us that are involved in this area, so that we share the information, we share the data, and we come up strongly together. Then lastly, I can see, Simon, you're looking at your watch. Lastly, and very quickly, becoming part of washing healthcare facilities community of practice. There is a big global community of practice on washing healthcare facilities. And I see Uganda is missing. Uganda has done a lot of work in washing healthcare facilities. We are not sharing, we are not networking. Great work that should go to the global level to influence the global agenda on washing healthcare facilities. I thank you very much for the opportunity.
Well, thank you very much, Jane. Great insights here. And Jane must have represented the virtual audience, but there are just a number of comments that I feel I need to read out. Silas Quemboy says, a person who intends to discharge effluent into water or land, this is a quote, a person who intends to discharge effluent into water or land shall ensure that the effluent meets the standards for general chemicals and microbiological discharge set out in Schedule 2 to these regulations. That's the National Environmental Regulations 2020. Did the study include an assessment of adherence to the above guidelines, especially in regard to wastewater treatment technologies in hospitals? Thank you. Well, there are quite a number of comments, but unfortunately, in the interest of time, I think that does it for us. Right now, ladies and gentlemen, I'm going to constitute a team of panelists who will be speaking to us about the calls to action, the action points that they feel ought to be addressed, and also telling us more about where the country stands and where they see us going in terms of realizing WASH across the country and upping the targets. I have the pleasure, if you could allow me, to ask Gerald to go up and take up a seat at the platform. Dr. Ronald from UCMB, Commissioner Joseph Epitu, delegated to Femin Achuba, Dr. Hillary, you're joining the panel. Commissioner Dixon, and finally, okay, UCMB is represented, ministries are represented. Finally, the moderator. Ladies and gentlemen, may I kindly ask you to move onto, so you can give me some space. Ladies and gentlemen, before you is a team of very distinguished persons, and again we're discussing WASH, where they see the gaps, where they see the opportunities, and what the future spells in the campaign for WASH. I'll begin with Gerald. What do you make of what has been presented so far, and what does it point to in terms of where you see the WASH initiative going?
Yeah, thank you. What I hear a great deal of is consensus. Consensus around the need, that WASH is real, the need to implement it at a parish level, at that front line of medical care. I see consensus around the need for funding, relatively obvious. And how do we allocate that funding? I see consensus around the need to bring in additional partners to support this work and to support provision of WASH to as many people as we can in Uganda. I see consensus around standards. And we're rapidly moving to a place where we have standards, which is amongst the most critical steps, because once we have standards, then we can build programs around achieving those standards. And then we can cost those programs. And that's one thing that our next step with the 54 healthcare facilities is to do some costing. What is it going to do? What is it going to cost to get to these standards that we're recently adopting? I see consensus around advocacy at the political level, at the community level, advocacy for more resources at the political level, and advocacy for behavioral change led by the good fathers, for behavioral change so that when people understand the wonder that is really WASH, clean hands, clean water, clean facilities, and the prevention that it creates, I see consensus. So I hear a great deal of consensus in this room. I think we understand, and the parties here understand.
Oh, amazing. Thank you very much. I'll move the mic to Dr. Ronald. Well, Uganda Catholic Medical Bureau is very pivotal in pushing the WASH initiative in healthcare facilities. Where do you see the bottlenecks, and how do you see the future with these new ideas and the innovations that are in place?
Thank you. Good afternoon once again. I am going to request to do 1 or 2 clarifications before I proceed. The first one should have been to the Director and the Commissioner for Ministry of Health, but since Aineviona is here, he will be using it in his communication. The faith-based private not-for-profit health facilities do not compete with public facilities. And that has never been the intention. It shall never be the intention. We complement. We exist to complement the services. And we probably believe that the people who initiated the PHC support that is coming to the sector is in this complementary spirit. And secondly, the Uganda Catholic Medical Bureau is the health department of the Catholic Church. So we are the technical arm of the Ministry of Health for the Catholic Church. So you can be assured that the Ministry of Health for the Catholic Church is fully represented. And one of them is Father Katavaz there, who is a member of the commission. So he will be presenting to the entire Ministry of Health of the Catholic Church the findings, some of which we have seen in here, that we probably can do. Some can be done internally. There are things which may not require really to go out to the partners. They are just as basic as saying, this door is for so and so, and this door is for so and so that men and women do not line up for one entrance and interfere with the you might interrupt with what I was going to do if I see someone who is not of my gender or sex behind me. So, sex or both? Or both? Okay, biologically. Fine. So where do we see this going? The Catholic Health Network has been conducting what we call patient satisfaction surveys for the last 15 years. And part of the survey questions are about the environment, the toilet, sanitation, access to toilets, and how they look like. And we use this as a measure of quality of care. So it's a proxy for quality of care. But from the findings that we got here today, I think we need to expand it. Not only accessing water, but what is the quality of the water that you're accessing, or what's the amount of water that you're accessing. So how do I see this moving forward? We would like to assure the members of the institutional sustainability of some of the resolutions that we shall take from here, that these are things that will stay and we shall implement and will be there. I would like to thank the government of Uganda. Government of Uganda has been giving the PNFP subsector the primary health care grant since the late 90s. Part of this money, the guidelines stipulate that money should be used for operation and maintenance. Money should be used for outreach and prevention services. So we applaud the government. As a proportion, the PHC accounts for between 8 to 10% of the total financing of the facilities. If they could increase a bit, we probably would increase a bit on that aspect of the prevention, promotion, and other community health interventions. Thank you.
Thank you very much. Still, you're going to move the microphone. I think we might need to sanitize a bit more. I'll take the next question to Famin Akuba from the Ministry of Water and Environment. There have been quite a number of commitments signed at the UN level in terms of improving access to water and sanitation, to which Uganda is a signatory. I believe you're quite aware. How much effort is your ministry making to ensure that you're up to the game?
Thank you very much. I want to appreciate this meeting that we are having. For me, it is the first time that we are interacting with what are they called? PNFPs. And of course, we've been interacting a lot with the Minister of Health. Yes, we have signed, government has signed international protocols to implement water, and all of these protocols are recognized in the Constitution of Uganda. And our mandate as Minister of Water is derived actually from the Constitution and also the Local Government Act. And international protocols, as I've already said, are recognized in the Constitution of Uganda. Our mandate of pushing forward the water agenda to be able to serve the people of Uganda and the country is through initiation of policies. That's one of our mandates. We initiate policies and legislation. Every policy and legislation on water is initiated by Minister of Water. And also, we set standards and we do inspection. Our role is to do inspection of the water facilities. We also do monitoring. We do monitoring and evaluation. And we do coordination. We coordinate with the stakeholders in the water and sanitation sector. And we also do provide technical backstopping in relation to water and environment services. And we have what I call policy frameworks that help us to achieve what we are intended or mandated to do. And one of these policy frameworks is the preparation of the budget framework papers, which culminate into ministerial policy statement, where budgets for the services are included, and which eventually result into outputs and therefore outcomes in the long run. We also do annual program reviews. We used to have the sector reviews, but we have now moved on. It is no longer sectors, we have programs now. And we did our first program review last year, and the next is going to be in October, September, October. But just this week, on 28th, we had the semi-program review, which was very successful. And in these program reviews, it provides a forum in which all the stakeholders in the program are brought together to do joint planning and joint reviews, which is a very good opportunity for addressing challenges and also for identifying priorities. And I would like to say that I think the PNFPs are free to attend such forums, and a lot will be learned on what to do and how to move forward. And then
Thank you.
I want to say before I leave this, we have challenges as we do this, and these challenges include many of the issues that were raised by the audience here. We have the challenge of operation and maintenance. Indeed, people have raised the issue of water services being provided in health facilities and they are not maintained. It's a very big challenge, and so I call upon the stakeholders to ensure that when we provide water facilities, in these facilities, they should be maintained. And then also the issue of the inadequate funding and also budget cuts. Of course, there's a challenge of COVID-19, which also stagnated our operations. And then we have inadequate coordination and networking. Of course, there is some coordination, but I think that we need to improve on it. And we get on the PNFPs on board as part of our stakeholders and the network.
All right, thank you very much.
And then
thank you, Famina. In the interest of time, I'm afraid I need to stop you here. Thank you very much. Shall we sanitize? Well, Dr. Hillary, the spotlight in this study was more, or rather essentially, on PNFP, where you are among the heads. How accurate is this report in the first place, and where does it leave you as UPMB?
Thank you very much. I believe it is accurate. One, we were involved and engaged from the time of planning, but also when it was being implemented, we were also involved. And so at many stages, we were involved and saw what was happening. Definitely questions still will continue to come, and we probably need to go down and look at the details of this data to be able to go down on ground to work with this information to cause improvement. So where does it leave us? That's what you need to know. So I think for me, there are 2, 3, 4 things which have actually resonated in the comments that we've had here. The first thing is that you cannot hear some of those very bad spots and not respond. Hearing something like no basic sanitation at 24%, that really sounds bad. You hear something like no basic water source for 17%. That is scary. I think and I'm glad that they've brought this out. So we'd want to go down and respond to this for starters, because even as we plan for how we're going to do the rest of the interventions, we want to be able to respond to where gaps have been identified. But beyond that is really prevention. How do we prevent these situations from happening? So going down to the planning processes, supervision, the monitoring, and which is what they've done. I think, how do we put systems in place so they're not only passing, so people can hear that the team is coming to assess and put things together, remove things from the store and put them out, but is it sustained? How do we monitor and use this information to cause improvement? 2, 3 other things. I think there was, a comment on there was a comment on prioritization, and I think that goes back to management and leadership. We do have the health unit management committees and boards in some facility. How do we engage them to be able to support and supervise this process? So you have the management at the facility trying to implement, but if you have the HUMICs and the boards working well, they should be able to supervise this and make sure that we have the right kind of outcomes. Just also to mention, in terms of appreciating the connection between wash and health. Until COVID came in and scared us a little bit, people used not to mind so much about washing hands. When you say global warming and the environment, some people will say, so what is the connection? I think we need to help people to appreciate how this really affects their health so that it is prioritized in the different places that we work with. Then definitely advocacy at the different levels. We did hear that the resources come and they're earmarked. Wash, but somewhere as it goes down there, and I think it came clear from the responses that we got, as it comes down there, people say, can we pay salaries, can we do this, and it is pushed aside. So the advocacy and monitoring. So as UPMB, really, my take home from this is that how do we set structures up to prevent, but also to monitor and support, and also cause change where change needs to happen at the facilities. Thank you.
Thank you very much. And I'll move the microphone. Well, before I move the microphone, actually, where in the priorities of UPMB is WASH?
We have a health system strengthening component, and under health system strengthening, we do have a section that deals with quality and safety.
So it's only under.
So what's
not an independent unit?
So it is, where I use the word under because it is a section of the department. But what happens is that we integrate it. So each section and each department integrates into all ongoing services. So that happens with quality and safety.
Well, thank you very much. Let me move on to Commissioner Moses Kabanji. How are awakening the findings that were conducted by Engineers Without Borders and PACE, especially on private, non-for-profit healthcare facilities, and how different is the situation in government facilities?
Well, probably I'll begin from, unfortunately, I wasn't here when the findings were being shared, and sorry for that. I had to participate in chairing of another meeting. But I think I've read some document that has a few of those findings that you produced. I think when I look at the findings that came from the PNFPs, the situation, well, is not good, but it's not more alarming compared to our public facilities. I told you in the morning that we did a bigger assessment of all our public facilities in the country. And surely, there is a big difference when you look at the findings. There are, I think, 4 service indicators. We use basic He knows it them very well. Limited, basic. Then the other one is what? Safely managed and no service. So in the PNFPs, there are some areas, some indicators that really you see. For example, we've not seen them talking about no service. But now no service means either they don't have a public, there's no latrine for the clients or patients, or there's no water point. That means no service. I have not seen that in the report that was shared with me. But for the public facilities, we have those facilities that are registered no service. So it means on our public side, and I already mentioned this, there's a lot to do. We, compared to the PNFPs, there is some level of investment and some commitment. Maintenance of these structures is a little defined when you go to the PNFPs. But in the public facilities, all these systems are actually not very active. In the PNFP, you can even get a person who is in charge of WASH, who is in charge of some of these issues that are related to WASH. For example, if you went, most of them have IPC focal persons, and they're actually active. They even have these IPC structures, very active. But on our side, in the public facility, it is even alarming when you ask the in charge of the facility, and it does not even know whether such a committee exists or whether there is such a person. So I would say, when you comparisons between the two, I think the PNFPs are doing a little better.
Oh, okay. I'll have just one more comment, and I think it will come from Gerald. Gerald, we want to benchmark, because here, one of the comments that have been made is about behavior change. How do you do it in the US?
Training is where it starts. And let me take that back. Standards is where it starts. And so we're recently now, World Vision, UNICEF, the government have been working on standards, and we implement the standards and training on the standards, and there's behavior involved in implementing those standards, training on that behavior. Then we monitor, as the gentleman here had spoken to, we monitor how those standards, how the people are implementing those standards. And we can do that in a number of ways. We can actually look at the existing condition of the facility that they're taking care of, or the room, or how clean it is. Is it stocked with supplies? We can actually look at the physical facts on the ground. We can have forums with the staff and understand what their challenges are, and understand if maybe there's a fall off from the standard. What is the reason for that fall off? Is it more training? Is it we need better supplies? We need better maintenance? So we understand where the gaps are between the standard and the actuality as we see it on the ground in healthcare facilities, in the parish healthcare facilities. So if we understand the reason, then we can come up with corrective action. But it all goes back to a certain level to data collection. Have a standard, understand where we compare to that standard, and then adjust our training, adjust our supplies or whatever else that we provide to that healthcare center to continue to meet that standard. We will never get every healthcare center up to every standard. That's something that we haven't got in the United States. But we can always try, and we can always work at it.
In your opinion, where do we go from here?
I think I'd spoken about consensus. We're going to make a presentation to the senior staff. That's a good first step. I think we don't lose touch with the people in this room, the people that are passionate about making this happen, that we somehow create some energy around this issue with the active players. It might be a quarterly stakeholders meeting. It might be, and Peter, I know, would be happy to help lead that, a quarterly stakeholders meeting where we don't stop this conversation. From Engineers Without Borders standpoint, you know, I can't speak for the ministry, but I can speak for us. We will continue to support with our technical knowledge what actions the group, as a group, takes. The gentleman mentioned quality components. We can help with that. We can help select quality components that last for 10 or 15 years. We can optimize the components of repair, the size of the pump, the size of the solar array, the piping, so we get the most component, the best quality for the least dollars. That's what engineers do. Anybody can grab the biggest pump and stick it in a hole. Engineers grab the most effective pump and put it down there. We continue to support that. I can't speak for other people, but that's where I see our role is, with our technical knowledge, being a partner and advocating for good quality work in the healthcare centers.
Well, that's the last question to all the panelists. Where do we go from here?
Thank you. For the UCMB, or the Catholic Health Network, it's the institutionalization and ensuring that the governance, the management, and the staff pick on some of the best practices. Like I said earlier, we monitor the quality and patient safety within the UCMB network on an annual basis, and this is part of the accreditation process. We have about 500 Catholic-founded health facilities in Uganda, but 297 are accredited, so they have to go through a sieve. And we can include some additional 1 or 2, 3 components for WASH, for purposes of accreditation, but also to institutionalize this within the leadership, governance, and management of the health facilities. To us, this is something that we can take on now. I'll give just an example. So some of the facilities don't have incinerators. The government policy is clear. A health center 3 must have an incinerator. If you are admitting people, you are conducting deliveries, where are you putting the things? Now, the coordinators of health of the dioceses that we have in here, who are the equivalent of the ministers of health at the diocesan level, and when I look at, for example, Father Katabazi is the DHC of Masaka, and Masaka diocese is over 10 districts. Over 10 districts, so you are bigger than even a governor in terms of health. Your job is to ensure that each and every UCMB accredited facility implements the standards of Ministry of Health as have been provided. Where do we go from here? Is to request the Ministry of Health to increase the resource envelope. The money as a proportion to the total is going down. The figure is going up slowly, but as a proportion, it is going down. And if they could revisit this, you know, and say, thou shalt there be, maybe let every facility have free electricity if it ever happens, then we shall be very glad to make sure that we maintain that. The PHC they give us, we use for maintenance, we use for operations, and we are ready to continue doing that.
Well, thank you very much. Madam Famina, at both policy and supervision, where do we go from here?
As already mentioned, we need to improve on operation and maintenance, because once we deliver the wash services, they need to be operational and well maintained so that they don't escalate the health problems of the patients. And also we need to strategize on funding. We are aware that COVID has affected funding, and so we need to look at other ways, alternative ways of funding. And also, we need to improve on coordination. I already said we are happy to meet the PNFPs for the first time, and we, I think, need to continue with that kind of networking for the future. And we need also to generate information. I'm glad that this forum has been able to provide a lot of information which we did not know about. And that's the way to go. We need to generate this information for policy and decision making. Finally, climate change is one of the challenges that we meet, and we need to mainstream issues of climate change in all what we do. Thank you very much.
Well, thank you very much. Dr. Hilliard, same question. Where do we go from here?
Thank you very much. Because this is very PNFP specific information, I think dissemination will be very important. Taking this information back to the team and telling them this is what it looks like. How do we use this information? And then building a critical mass of people that, that agree, that can want to move with this finding to cause change. And then strengthening systems will be the next thing we want to do. Focal persons per facility, making sure that at the facility level, the right systems are in place to stick to or adhere to the WASH policies. Then benchmarking, very important, learning and adapting. There are some facilities that actually did well. How can we learn from them and have a cost-effective way of doing this? You know, sometimes you think it's just only about money, but there are facilities that are probably at your level, even under in terms of resource, and are doing well. How do we benchmark from them, learn, and then be able to adapt this into practices that can be scaled up to other facilities? The monitoring is very important, collecting of data frequently. I think Ministry of Health has given us guidance on this. We know how to do this. How do we make sure this is happening? So the data is available, and we can flag facilities and be able to reach out to them and say, we are seeing something here, what is going on, how do we help you? And then finally, integration. How do we integrate WASH in everything that we do? People can go and say, for example, in a facility I'm doing a supervision for TB. You cannot do TB without WASH. You cannot do HIV without WASH. You cannot. If we integrated this in everything we're doing, then we will be able to raise that critical response that we want to see. Thank you.
Thank you very much. Commissioner Moses, now that you're going to have the report and that you're inviting the team to go and discuss with you in senior management, where do we go from here?
Thank you for that question. You realize that the submissions made by the colleagues, many of them actually anchor on our efforts. But what do we do? One is that we want to make sure that we influence the policy direction to ensure that there is a better understanding for WASH. And in that regard, I think we've developed a number of guidelines that are related to WASH in healthcare facilities. We actually have a WASH in healthcare facilities guidelines, national, and we are going to launch it on 12th of July. And most of the partners and the other ministries have been invited. I think there is a copy there. It's a very beautiful one. And all of you are free to come. We'll give you copies, especially if you are implementing in our healthcare facilities. So we want to change, because originally there was no guideline to support implementation of WASH interventions in healthcare facilities. So we are changing that. We have a WASH in healthcare facility guideline. We are also working on the IPC guidelines. Soon we shall be through. We've worked on indicators for monitoring under IPC and WASH. We are working on a WASH handbook manual, something like that, and that is the direction we are taking, so that we can have our health workers and the other governance structures appreciate WASH. Two, we want to continue with the advocacy, because we think we should have financing for WASH. So we'll continue engaging. We're going to meet so many other stakeholders, be able to engage, and be able to talk about WASH so that we can improve WASH participation, but also WASH financing. I'm glad that yesterday we met most of the CSOs in the country and our other the NGOs, and we're talking about something like this. So we are going to continue advocating. And I think next time we shall even grow our team bigger, the MOH team. I'm glad that Minister of Water is actually here and a little more than us. I think that is one of the issues that we should be able to look at. Then also coordination. I think we've been having challenges with coordinating our WASH efforts. You find places in one region, they are doing something, then around there, Japaigo is also doing the same thing in a nearby. So we want to improve coordination, want to coordinate better, coordinate with our other sister ministries, coordinate with the WASH players, and even coordinate with the other development agencies to ensure that we improve WASH. And then two more things. I think data collection, you mentioned it. As Minister of Health, we are developing a sanitation monitoring information system, which is going to capture data. Actually, it's not only Minister of Health. We are doing it together with the Minister of Water. As they capture indicators in the community, we shall be able to monitor indicators of each facility, because it will be real-time reporting, and we shall be able to tell where the problem is, but also be able to share information about, with the management of the different facilities. And then probably lastly, of course we've started on this, intensifying WASH supervisions and quality assessments in the area of WASH. Actually, this is one of the core things that we are doing with the Quality Assurance Department of the Ministry of Health.
Well, thank you very much, ladies and gentlemen. Shall we put our hands together for this very formidable team of panelists? And as I thank you, as I see you off, ladies and gentlemen, we are very sure that some of the resolutions and the ideas that we've gathered here are going to be put in real action. Action begins today. We shall be washing our appetites shortly. Coupons are being issued. Please get yourself a lunch coupon, but I'll invite Engineer Peter to give a vote of thanks. No. I'm going to invite Mr. Joseph Epitu to speak on behalf of the ministry as he gives some concluding remarks, and thereafter we shall have a vote of thanks and administrative announcements. We can resume our seats, ladies and gentlemen.
Thank you very much. Thank you very much, moderator. Once again, my name is Joseph Epitu, Commissioner, Water and Environment Sector Liaison in the Ministry of Water and Environment. And I'm privileged to stand here to represent my minister, my ministry on this occasion. The honorable members of parliament present here, Engineers Without Borders, our very good partner, the non-state actors, particularly the religious colleagues present here, the media, our colleagues from the other line ministries, Minister of Health, Minister of Water, distinguished guests, ladies and gentlemen. I want to begin by submitting apologies from the Permanent Secretary, Minister of Water and Environment, who should have been here with us, but then this event got him out of the office and requested me to step in for him. Colleagues, I think on my part, this is a very important event. Why? Because I am meeting Engineers Without Borders from another angle. Engineers Without Borders has an MOU with the Ministry of Water and Environment to support us in terms of professionalizing our professionals, the engineers, and we have been implementing that MOU since 2018. So I'm happy that when I come to the health sector, again, I meet Engineers Without Borders doing a very tremendous job for the country. So Engineers Without Borders want to thank you, and we want to appreciate on behalf of government the support you are giving us in terms of technical assistance, and the results are out for all of us to see. This report in itself is a very good document that will inform government policy. In the water sector, you have already developed for us guidelines for operation and maintenance of solar water supply systems, and I know we are again working with you to develop, to review our design manual. So thank you so much, and you send our regards to back home when you get back. Let me also take this opportunity in a very special way to thank the private not-for-profit healthcare providers. And in a very special way, I see here representatives from the Catholic Church. The Catholic Church has been very, very instrumental in supporting government to ensure that our people have good health facilities. And when I came here and I saw the nuns, the priests, I thought I'd entered the wrong venue. Not until I listened to the presentations and I learned that the study actually focused on the private not-for-profit health facilities. We would like to thank you so much for the contribution you are giving to the country, to our population, and this is something you have done historically, not only for the health facilities, but also for the education sector in Uganda. At least those are the ones I know of very critically, but I know you are also, the Catholic Church also has its footmarks everywhere. We want to thank you and want to appreciate your support. This report that we have just discussed today has been a very, very good eye-opener for us. And you have actually given us a very big workload. Myself, me, and my colleague Moses. Moses, I see this report as a continuation of the work we started yesterday. Since yesterday, we have been moving with my colleague Moses from function to function, talking about WASH. And when this report was being presented here, I could capture critically about 4 takeaways. One is the report has given us the statistics. As government, it's now our responsibility to take forward. And like the director, our senior colleague, the director, already communicated, this report will be presented to the senior leadership of Ministry of Health. And I'm sure they will pick keen interest in it. So the statistics has given us the magnitude of the problem. We now need to translate those statistics into decisions. And as government, we pledge to do that. The report also clearly highlights what I could call gaps in coordination. And that's where Commissioner Moses and myself come in. Part of my responsibility as Commissioner Water and Environment Sector Liaison is to coordinate development partner support to our sector, but also coordinate non-state actors and ensure that we work together as a team. When I joined the Ministry of Water and Environment in the early 90s, our coordination mechanism on WASH was very, very strong. But over time, I see we have had a bit of relaxation. So this report again shows us that we need to coordinate better. And moving forward, again, that's the responsibility of myself and Commissioner Moses. The non-state actors should be brought much closer to us, so that some of these gaps which are being highlighted in these statistics should be picked, even informally. For instance, moving forward, we'd like to see the non-state actors very active in our sector reviews, our program reviews, and our other governance structures, so that we know, for instance, which health centers lack water facilities, which ones have water facilities that have collapsed. As a Ministry of Water and Environment, we have regional structures. These regional structures, one of their responsibilities is to work closely with our partners in the various regions. And we have headquarters in Mbarara for the west, in Mbale for the east, in Lira for the greater north, and in Wakiso for the central. We have just opened offices in Moroto and Port Poto. So we want to see, moving forward, that the religious or the not-for-profit facilities, health facilities, become part of the facilities we bring on our radar. And then we see a mechanism of working closely with our partners in that area. Fortunately for government, under NDP 3, we are required to implement the program-based approach to planning and budgeting. That means requires that all stakeholders should come together to align our activities to the government programs, government planning horizons, and also focus on our Vision 2040. So it's something that these statistics also encourage us now to do, so that we talk to each other, even without waiting for Engineers Without Borders to come all the way from the States to do for us a study. So I hope that this report is the beginning of much more closer engagement. The report also highlights the issue of capacity building and institutional strengthening. As government, we have been a bit laid back in terms of capacity building and institutional strengthening. And if we don't address the issue of the human resource, the tools that that human resource uses to deliver, and the enabling environment, we may put in very beautiful health center 4s, health center 3s, and they will lie there in the West. So I think, again, as government, the report lays bare the importance of addressing the issue of capacity building, institutional strengthening. And again, next time, I think, Peter, I wish we had also invited our colleagues from Ministry of Finance here. Because in the Ministry of Finance, when there are budget cuts, the first casualties normally is capacity building. And they even call it consumptive expenditure. And yet without, consumptive expenditure. And yet, without a trained human resource, we cannot treat our people. Without facilities, we cannot operate our people. And without a conducive, enabling working environment, our people cannot work and operate. A week ago, I saw on TV a video of a very beautiful school in Karamoja, which was constructed, and to date, there is nobody in the school. I think as government, that's something we should avoid. Finally, the other takeaway from this report is the issue of operation and maintenance. We need to seriously address the issue of operation and maintenance. The Reverend Priest in the table in front of me did talk about our attitude towards maintenance. And I think he was spot on. I forget your name, Father Robert. You know, as a country, I don't know whether it's our culture, the attitude towards operation and maintenance is so poor that sometimes we wonder where we came from. There are things which we don't even need development partners to come and do for us. You find a tree growing on a wall, and you know the roots of the tree will create cracks in the wall, but we leave it to grow, waiting for somebody from Europe, from the US to come and tell us that remove this tree. There are certain things we can do without resources. So I think we need to revisit our attitudes towards operation and maintenance, because some of these facilities, sometimes you go to a government institution and then you find a facility has collapsed, and when you ask, it's maybe only a nut, a bolt, which has got off a borehole. And then we are waiting, we are running to the district, we are running to our development partners. So I think we need to address the issue of operation and maintenance also from the attitudinal level. And in the same vein, I would request our non-government actors, particularly the religious leaders, you interface with the community more than we do. If in your Sunday sermons, you could make sure that you pass a word and educate our communities about operation and maintenance, maybe something will change. Otherwise, of course, as government, we shall take up the bigger bits, like when water infrastructure collapses and the requirements to bring it back to work is in millions. There, as a ministry, we normally come in. So I would like, as I conclude, want to request all of us to revisit some of those highlights, key areas: coordination, behavioral change, operation and maintenance, capacity building and institutional development. But above all, I want to pledge here that as government, we shall sit down, both Minister of Water and Environment and Minister of Health, and see how fast we can reactivate the existing coordination mechanisms between the two ministries in as far as WASH is concerned, and also Minister of Education, because WASH is handled by 3 institutions. We have the Ministry of Education and Sports, responsible for WASH in schools. We have the Ministry of Health, responsible for WASH in health facilities. And we have Ministry of Water and Environment. So we used to have very, very strong coordination mechanisms, and we would meet regularly. There was even the WASH Declaration of 1997, which is still very, very valid. And in that declaration, our leaders came up with the 10 points which they thought should take WASH forward. But we have since put those 10 points to take dust. So I think, again, this report could be the beginning of our effective coordination of WASH activities across the 3 ministries to ensure that our communities, our partners who are struggling to mobilize resources, feel that government is part and parcel of the process. So, ladies and gentlemen, with those remarks, I want to thank the organizers of this event. Once again, I want to thank Engineers Without Borders for continuing to work with us, support us as government. I want to thank the non-state actors. You are doing a tremendous job mobilizing resources and also mobilizing the resources, both financial and human, to support government. And we want to continue working with you closely to ensure that our communities get better quality services and also improved quality of life. I thank you very much, and I would like to bring this event to a close. Thank you very much.
Thank you very much, Mr. Commissioner. Very good remarks. I think we all agree that the issue of WASH cuts across all ministries, even ethics. Yes, it should be very unethical for anyone known to have WASH facilities anywhere, even security. So let me invite Engineer Peter to give a vote of thanks. Ladies and gentlemen, lunch is going to be served. We will walk out and then walk down the stairs. We will be directed to the place. All the other administrative announcements will be made there.
Our moderator and the commissioners who are still with us, and the other officials from the ministries, and those who have been online listening to and following these presentations. On behalf of the partners that we worked with during this assessment, UCMB, UPMB, and PACE Uganda, I want to thank you for accepting our invitation and coming here to be part of the presentation of the findings and to join the Ministry of Health to be ambassadors, to mobilize more resources to invest in WASH. We thank you and we hope that we can be able to continue this discussion under the leadership of the Minister of Health and the Minister of Water. Thank you very much. As the moderator has indicated, we'll be going for lunch, and the other administrative issues will be managed by Jawash and Sarah at the entrance. I thank you and wish you safe journey back home. Thank you.
Thank you very much, ladies and gentlemen. Thank you for your attention. That's it. Bon appetit. We shall have a group photo. Where do we go for the group photo? Can we come up here for a group photo, ladies and gentlemen, as a souvenir to carry the memories of the WASH report launch?